live at 7 a.m. Eastern Thursday morning. Join the discussion. President-elect Trump's choice for Health and Human Services Secretary, Congressman Tom Price, took questions from a Senate panel. The Georgia Republican, who has a medical degree, was asked about the Affordable Care Act, his current stock holdings, and the cost of prescription drugs. The Health, Education, Labor, and Pensions Committee is chaired by Senator Lamar Alexander of Tennessee.
Hearing will come to order. The Committee on Health, Education, Labor, and Pensions will come to order. Today we're reviewing the nomination of Dr. Tom Price to be the Secretary of Health and Human Services. Dr. Price, we welcome you and congratulations on your nomination. Welcome to you and your wife, Betty, who is here today with you, and I enjoyed having the opportunity to visit with you in my office and to learn from you about your plans. Dr. Price will be introduced today in a few minutes by Johnny Isakson, a member of this committee and Dr. Price's home state senator. Before Senator Isakson introduces the nominee, Senator Murray and I will each make a few introductory remarks. After the nominee makes his statement, we'll have the usual round of questions. Now, let me say something about the round of questions. Last night, we had a hearing of 3.5 hours. I had tried, as chairman, to be fair by following the same precedent we had for President Obama's 2 education nominees, by having one round of 5-minute questions followed by Senator Murray and me asking questions and wrapping up. I don't want to re-argue that because we spent a lot of that 3.5 hours arguing about the 3.5 hours. I've listened carefully to what my colleagues have said, and I looked back at the precedent for the Health and Human Service Secretary when that person came before our committee. Secretary Burwell had one round of questions. Sebelius, 1 round, plus Coburn. Dr. Coburn asked a question. Daschle, 1 round, plus 3 senators asked a question. Leavitt, 6 members asked questions in the second round. Thompson, 1 round, but it was a round of 7 minutes. Shalala, 6 members asked a second round. So what I've decided to do is, in an effort to try to treat President-elect Trump's nominee approximately the same as the way we've treated other nominees, is to have a single round of 7-minute questions today. That would be the precedent followed with Secretary Thompson, and that seems to me to give every member of the Senate more time to ask questions of the Secretary. This is a courtesy hearing. Dr. Price will be before the Finance Committee on next Tuesday. A number of the members of this committee are also members of the Finance Committee. We don't vote on his nomination. They vote on his nomination and will be the ones that report it to the floor if that's their decision. We have the hearing because we have some of the healthcare jurisdiction, some important parts of it, and we would like to talk to him about especially those issues. He has all of his paperwork in place before the Finance Committee, including the letter of agreement with the Office of Government Ethics, which is on the website and available to members of this committee as well as others. And so it's my hope would be that in our 7 minutes of questions that we'd have time to focus on the responsibilities of the Department of Health and Human Services rather than have a continuing discussion about the number of minutes. There'll be an opportunity following the hearing to ask written questions of Dr. Price as well. Dr. Price, if you're confirmed to lead the Department of Health and Human Services, you'll be running an organization that spends $1.1 trillion a year. It's always troubled me, actually, that you'll be in charge of spending more than the Congress actually appropriates every year. By that I mean the part of the budget that we appropriate and which is under pretty good control, which is the part that has national defense and national institutes of health and national parks and national laboratories. Over the last several years and for the next several years, that part is rising at about the rate of inflation. It's not adding to the budget. It's about a third of the total amount of federal government spending. But it's a little less than the amount that's in your department every year, most of which is entitlement spending, mandatory spending, and which is going up at a rate like that, while the rest of the budget is going like this. You'll be overseeing Medicare and Medicaid, mental and substance abuse programs. We just enacted in December of last year, and the President signed the most important reforms of those programs in a decade. Senator Cassidy and Senator Murphy were the leaders on that in this committee, along with Senator Murray. The Food and Drug Administration, we made important changes in the Food and Drug Administration, giving them new authority and new responsibility. For example, new authority to hire and pay the experts they need to move products and devices through the FDA at a more rapid rate, saving time and money and getting those devices into the medicine cabinets and the doctor's offices. That was Dr. Califf's #1 priority. We passed that into law in December. And then the implementation of Obamacare and the various proposals to repair the damage done by Obamacare and replace it with concrete, practical alternatives for the American people that give them more choices of lower-cost health insurance. Dr. Price, I believe you're an excellent nominee for this job. You were a practicing orthopedic surgeon for nearly 2 decades. You were a professor at Emory University School of Medicine. I read about the resident doctors in training who you taught. You served as medical director of the orthopedic clinic at Grady Memorial Hospital. In the House, you were chairman of the Budget Committee, and you've been a leader in deliberations over the future of our health care system. So you know the subject very, very well. One of the first responsibilities that you will have is to give us your advice about how to repair the damage that the Affordable Care Act has caused to so many Americans, and how to replace it, or to replace parts of it, with concrete, practical alternatives that give Americans more choices of lower-cost insurance. Let me give my view about how we might proceed on that, and then during the question and answer session, I will ask you more about your view. Following the presidential election, President-elect Trump said on 60 Minutes that replacement and repeal of Obamacare would be done simultaneously, his word. To me, that means at the same time. And then recently, Speaker of the House Paul Ryan said that repeal and replacement of Obamacare would be done concurrently. And then Senator McConnell said last week that we need to do this promptly, but in, quote, manageable pieces. Trying to interpret what those words mean, to me that means Obamacare should be finally repealed only when there are concrete, practical reforms in place that give Americans access to truly affordable health care. The American people deserve health care reform that's done in the right way, for the right reasons, in the right amount of time. It's not about developing a quick fix. It's about working toward long-term solutions that work for everyone. One way to think about what simultaneously and concurrently mean is to think about Obamacare in the same way you'd think about a collapsing bridge in your hometown, because that's just what's happening with Obamacare in my home state and in many other states. According to the Tennessee Insurance Commissioner, the Obamacare insurance market in our state is, quote, very near collapse. And across the country, premiums and co-pays are up. Employers have cut jobs in order to be able to afford the mandates of Obamacare. Medicaid mandates are consuming state budgets. In 1/3 of America's counties, citizens with federal subsidies have only a single choice of company to buy insurance from on the Obamacare exchanges. Without quick action next year, there may be zero choices on those exchanges. Their subsidies may be worth as much as a bus ticket in a town where no buses run. If your local bridge in Georgia or in Tennessee were very near collapse, the first thing you'd do, I would think, is to send in a rescue crew to repair the bridge temporarily so no one else is hurt. Then you would build a better bridge, or more accurately, in the case of health care, many bridges to replace the old bridge. And finally, when the new bridges are finished, you would close the old bridge. That's how I suggest we proceed. Rescue those trapped in a collapsing system. Replace that system with functional markets, as states develop their own plans for providing access to truly affordable health care, and then repeal Obamacare for good. First, we should offer a rescue plan so the 11 million Americans who buy individual insurance now in the exchange can continue to do so while we build a better set of concrete, practical alternatives. Second, we should build better systems, providing Americans with more choices of insurance that cost less. Note that I say systems, not one system. If anyone is expecting Senator McConnell to roll a wheelbarrow onto the Senate floor with a 4,000-page comprehensive Republican health care plan, they're going to be waiting a long time because we don't believe in that. We don't want to replace a failed Washington, D.C. healthcare system with another failed Washington, D.C. healthcare system. So we'll build better systems, providing America with more choices of insurances and that cost less, and we'll do this by moving more healthcare decisions out of Washington, D.C. and into the hands of states and patients, and by reducing harmful taxes. And we'll do this carefully, step by step, so that it's effective. Finally, we should then repeal what remains of the law that did the damage and created all this risk. I know that the President-elect has said that after you are confirmed, which is, I hope, is fairly early in February, that he will propose a plan to Congress. I look forward to that plan, and I know you can't tell us what that plan is today, but I do look forward to hearing from you how you suggest we approach this. We want to do this right. We want to sequence the events carefully and adequately so that Americans have concrete, practical alternatives in place of what is there today. And we want to make sure that the parts of Obamacare that are repealed are replaced before the repeal becomes effective. Senator Murray.
Thank you very much, Chairman Alexander. Thanks to all of our colleagues that are joining us today. Congressman Price, congratulations on your nomination, and thank you to your wife, Betty, who I know is here with you. You're well. But before I speak about this nominee, I do want to say that we remain deeply disappointed in last night where Democrats were blocked from asking more than one round of questions on Betsy DeVos, who's the nominee for Secretary of Education, and are disappointed that we are rushing this hearing as well. Mr. Chairman, you said 7 minutes, but I will just say I don't think any of us in prior nominees that you keep pointing to ever thought if I don't ask for another question, I have just set a precedent. In fact, I think that there is no example of any senator asking to do a question before and being turned down. So these nominees in a new administration that many people have questions about deserve to be asked questions, scrutinized in public before we have a choice to make on the floor of the United States Senate on both sides of the aisle in terms of whether we vote yes or no. That is why we think it's extremely important that we are allowed the opportunity to ask second rounds of questions after we have heard all of the questions. And today we have 3 or 4 committee hearings going on at the same time as this, so it is extremely challenging for our senators to be here on a nomination they care deeply about, on a subject that we care deeply about. So I would just like to point out again that several nominees that have come before, if we're going to talk about President, Secretary Leavitt, President George Bush's second HHS Secretary, 5 bipartisan senators participated in a second round. Senator Daschle, President nominee, Obama's first HHS secretary, 3 bipartisan senators participated. And again, it is unprecedented for a chairman to turn down a member who has a question to ask. So for the record, I would just like to ask consent to put parts of the record of the nominees of Michael Levitt, Andrew Van Oschenbeck, and Tom Daschle into the record of this hearing.
Oh, that'll be fine.
And again, our members have questions because this nominee is going to have jurisdiction over the health care and lives of millions of Americans, and we want to know where he stands before we make a decision, yes or no, on our imprimatur to him to be there. So that is why it is so important to members of our community. Now, having said that, I want to say this. The health of our families and communities could not be more important to our strength as a nation. When a young child goes to school healthy and ready to learn, she's better prepared to succeed. When women are empowered to plan their families and pursue all of their dreams, our communities benefit. When workers have access to quality health care that they can afford, our economy grows. And when seniors are able to trust that the guarantee of programs they have paid into, Medicare and Social Security, will be there when needed, we live up to some of our country's most vital responsibilities. The Department of Health and Human Services has a critical role to play in our ongoing work to meet each of these goals and many more. That is why in evaluating a nominee for Secretary of Health and Human Services, I consider whether the nominee has a record of putting people first, not politics, not partisanship, or those at the top, whether they will put science first, not ideology, and whether their vision for our health care in our country would help more families get quality, affordable care or take us backward. Congressman Price, I have serious concerns about your qualifications and plans for the department you hope to lead, and I'm looking forward to hearing from you today on a number of topics. I'll start by laying out issues with what your record suggests about your approach to our nation's health care system. Just last week, you voted to begin the process of ripping apart our health care system without any plan to replace it, despite independent studies showing that nearly 30 million people would lose health care coverage. Even though more and more members of your own party are expressing serious doubts about its ability to unify around a plan, and knowing that in a matter of weeks you could be leading the department whose core responsibility is to enhance America's health and well-being. My constituents are coming up to me with tears in their eyes, wondering what the future holds for their health care given the chaos Republican efforts could cause. President-elect Trump and Republican leaders have promised the American people their plans to dismantle our health care system right away would somehow do no harm and would not cause anyone to lose coverage. In fact, just days ago, President-elect Trump promised, quote, insurance for everybody. But Congressman Price, your own proposals would cause millions of people to lose coverage, force many people to pay more for their care, and leave people with pre-existing conditions vulnerable to insurance companies rejecting them or charging them more. So I will be very interested in hearing your explanation of how you have your plans to how we would keep the promises your party has made to the American people about their health care. Medicare is another issue I will be interested in hearing about today. President-elect Trump campaigned on promises to protect Medicare and Medicaid. You have said you plan to overhaul Medicare in the first 6 to 8 months of this administration in a way that would end the guarantee of full coverage that so many seniors and people with disabilities rely on. You have put forward policies that would shift $1 trillion in Medicaid costs to our states, squeezing their budgets and taking coverage away from struggling children and workers and families. And while President-elect Trump has said that Medicare should be able to negotiate lower drug prices for seniors, you have repeatedly opposed efforts to do that. You even went so far as to call legislation on that issue a solution in search of a problem. I disagree. This is absolutely critical for families in my home state, and I'm eager to hear how you would reduce the burden of prescription drug costs in our communities. As a woman, as a mother, and a grandmother, and a United States Senator, I am deeply troubled by the ways in which your policies would impact women's access to health care and their reproductive rights. I have serious concerns about your understanding of women's needs for basic health care like birth control, given your expressed doubts on this topic, your proposals to make women pay extra out of pocket for birth control, and your repeated efforts to defund our nation's largest provider of women's health care, Planned Parenthood. And I'm also very focused on the role of the Department of Health and Human Services in strengthening and protecting public health. So I want to hear from you about whether and how you would uphold the gold standard of FDA approval, and, for example, how you would approach important programs and rules intended to keep tobacco companies from luring children into addiction. Finally, as I discussed at our hearing yesterday, I believe firmly that especially as the President-elect tries to blur lines around conflicts of interest, it is critical we not only do everything in our power to hold him to high standards, but we do the same for Cabinet nominees. That's why I was so appalled that with 4 of the President-elect's nominees currently serving in the House of Representatives, House Republicans attempted right out of the gate to get rid of the independent Office of Congressional Ethics. Now, luckily, they heard loud and clear from people across the country it wasn't acceptable, and they backed down. Congressman Price, the Office of Congressional Ethics has now been asked not only by Democrats, but by consumer advocacy group Public Citizen to investigate serious concerns and questions about your medical stock trades during your time in the House. I and other Democrats have repeatedly called for hearings on your nomination to be delayed until such an investigation is complete. It is disappointing to us that instead Republicans are moving forward with your nomination before we have all the facts. I hope you've come prepared to be fully transparent with us in your explanation. So I've outlined just a few of my questions and concerns about this nomination, and I know in light of Republican efforts to take our health care system in a vastly different and harmful direction that are shared by millions of people across the country who can't be here today. With that in mind, it's crucial that the voices of people who will be impacted every day by choices made under this administration are part of the process when it comes to the President-elect's Cabinet nominees. So I just want to say I'm very pleased that tomorrow Senators Warren and Stabenow will be hosting a forum with witnesses who can speak to the impact of health care providers like Planned Parenthood, the importance of the work done in the Affordable Care Act to expand access to mental health care and substance abuse treatment, and the ways in which the full guarantee of Medicare has helped keep them financially and physically secure. There are stories across the country like this of lives saved and strengthened because of the progress we've made to expand quality, affordable health care. I urge my Republican colleagues to attend and to prioritize what is best for these women and men and families, not what's best for politics, as they consider each of the decisions in the coming weeks. Congressman Price, as we begin this hearing, I would ask you to be as transparent and frank as possible about your views and your plans for the department, and urge you to commit to providing us with additional information and answers to any follow-up questions we have in a timely and thorough manner. I'm looking forward to what I hope will be a rigorous and open discussion today, and I hope that we all arrive at the right decision for the families and the communities that we serve. Thank you, Mr. Chairman.
Thank you, Senator Murray. Before I introduce Senator Isakson, I'd like to put in the record the information about the last 6 hearings that we've had here without going into detail. The current Secretary, 1 round of questions. Secretary Sebelius, 1 round with 1 member asking a 2nd round. Daschle, 1 round plus 3. Levitt, 6 members ask a 2nd round. Thompson, 1 round of 7 minutes each. Salela, 6 members ask a 2nd round. So my decision is that rather than give 6 of 23 members a 2nd round, that it would be better to let every senator have 7 minutes. Now, Senator Isakson.
Thank you, Mr. Chairman. I'd like to ask unanimous consent that the remarks that were prepared for me to read this morning be submitted for the record.
They will be.
Because I'm not going to read them. I have a unique honor and privilege to introduce a friend of mine for 30 years, someone I know to be a great politician, a great practicing legislator, a great family man, a great community servant, and a great friend of mine. It's an honor for me to do so. And I want to thank each of you for taking my call before this meeting today when I called you to ask you to listen to what Tom had to say, because I think you'll be impressed with what you hear, no matter how tough the question might be. You know, I approach this introduction as if I'm being asked what I would look for in somebody who I wanted to entrust with $1 trillion of my money, the quality of my health care, and the future of the American quality of health care. And I'd look for 5 things. First, does this man understand the American family? Not only does he understand it, but his wife Betty is here. Betty, stand up. She'll tell you he understands the family. And his son Robert's not here because he's in Nashville, Tennessee, singing country music and writing country music songs, which I know the chairman would appreciate. And he's a fine young man, and I enjoy working with him. Tom is a great family man, member of Roswell United Methodist Church, active in his community, active in the state legislature, active in doing what's right for his community. He's a good man and understands the family and the value of the family and the value of health care to every family. Second thing I want to know, is he capable of handling $1 trillion? You know, $1 trillion is a lot of money. It's actually 1.1 trillion, but when you get to 1.1, why worry about it? It's a lot of money. It's more than we appropriate, as the chairman said. He's been chairman of the Budget Committee in the House of Representatives. He served in the Georgia legislature, leading appropriations for many, many years. He's run one of the largest medical practices in the state of Georgia. In fact, Tom Price is one of those people that put together what's known as Resurgence Orthopedics. They happen to be my doctors. In fact, they saved my son's right leg 26 years ago in a terrible automobile accident. I understand the value of Resurgence Orthopedics and what Tom has done. It's now the largest practice in our state, a well-run practice, and a practice that's set up as an example of how to do medicine in the 21st century. I want to know that my nominee for Health and Human Services understood the health care business. Well, who better to understand the health care business than a doctor? Even better than that, a doctor who's married to another doctor. Tom and Betty met at Grady Memorial Hospital when they were doing their residencies. They fell in love there, and they fell in love with the practice of medicine. And I've watched them over the last 30 years participate in activities in our state, whether elected or not, that contributed to the betterment of health care in our state, the betterment in hospitals like Grady Memorial Hospital, which is the largest crisis hospital and trauma center we have in the state of Georgia, saving lives every single day. They would have probably not been there today had it not been for people like Tom Price, who gave of his time and his effort to see to it we raised the money necessary to keep Grady open. I'd want to know they had some experience with the legislature, because, you know, if you get a chairman of Health and Human Services to come in, you give them a $1.1 trillion budget and then say, go talk to this 435 people over there and convince them of what we need to do to change the law. That's a pretty tall order. You'd want to find somebody who's served in public office. Tom's been in the State Senate of Georgia, was the first elected Republican leader of the Georgia State Senate in the history of our state. He served in the Congress of the United States. In fact, he improved the 6th District remarkably when I left and he was elected to replace me. The intellectual level went way up when Tom came, I can promise you that. And he's done an outstanding job being reelected 6 times to the United States House of Representatives, serving, as I said, as Budget Chairman, as Study Committee Chairman, and as a very active member of the Congress of the United States of America. I'd want to also know if he was an accountable person and believed in accountability. Tom Price believes in accountability. He's one of the rare one of us. In fact, he may be the only one of us, and I know this is true, that reads all the bills. In fact, when I need to know something about a bill, rather than read, I call Tom Price to give me advice because I know he's read it. Sometimes he's boring, but he's always knowledgeable. And it's because he does his homework, he does it right, he believes in his responsibility. Now, I'm going to mention a couple of things that have been said negative about Tom, and I want to address them straight up because they're wrong. In fact, I did on the floor of the Senate yesterday afternoon when Chuck Schumer took this case of Zimmer Biomet and tried to make it into a major case. Zimmer Biomet is a 26-share stock that Tom Price's broker who manages his account bought for him at a time Tom was unaware of the purchase. It was 2 months after the House had acted on a medical device bill. There's a term of art called desperate impact, where you take 2 facts that are unrelated and you put them together to indict somebody for a wrong, when in fact nothing wrong was done at all, and that's the case there. The Zimmer Biomed, a $2,674 stock purchase, took place without Tom's knowledge because his account is managed by someone else. His knowledge of that purchase took place 1 month later after the disclosure was made. He didn't even know about it at the time that it was made. So the allegations that were made yesterday on the floor of the Senate are patently wrong by taking two correct things, putting them together to make an incorrect thing. Now, second, something else has been said that I have working knowledge of. Tom was accused of not being for saving Social Security for seniors. Now, I'm 72 years old. I ain't going to stand up here and try to get y'all to prove somebody's not going to protect Social Security, because I got some of it. But let me tell you a little story about Tom Price. He and I got a phone call 6 months ago, I guess now it's been 8 months ago, from AARP, asking us if we would travel and do town hall forums for AARP on saving Social Security. Now, why would somebody call Tom Price, a congressman, or Johnny Isakson, a senator, to be the organization that represents seniors, to go on the road and do town hall meetings about saving Social Security if they weren't for saving Social Security? It's just incongruent, and it doesn't make any sense. Lastly, one of the best votes I cast 4 years ago for cabinet members was a vote for Sylvia Burwell. When she came before this committee and the House and the Senate Committee on Finance, I was on both committees as I am today. She's an articulate, intelligent lady. There was a lot of reason for me as a Republican in the minority to say, oh, I'll just throw a throwaway vote and I'll vote against her because she's a Democratic nominee. But I listened to her answers, I studied her history, I watched her actions, and I proudly voted for her. And today she's a professional friend of mine, and we'll miss her in her office. But there's nobody better qualified to replace Sylvia Burwell than Tom Price. I voted for Sylvia Burwell with pride, and I'm going to vote with Tom Price with pride, because I know he's the right man for the right job at the right time for America. He's my friend, and I commend him to you, and I urge you to vote for him in his confirmation.
Thank you, Johnny. God bless you.
Thank you, Senator Isakson. That's much better than whatever was written for you to say. Dr. Price, welcome to the committee.
Thank you, Mr. Chairman. Chairman Alexander, Ranking Member Murray, and all the members of the committee, I want to thank you all for the opportunity to speak with you today and engage in, as the Ranking Member said, in a discussion about the road ahead for our great nation. I want to thank Senator Johnny Isakson for his generous introduction. As he said, we've known each other for 30 years, and I'm so grateful for his friendship and his kindness. And our state is blessed to have had his service and his leadership. I wish also to especially thank my wife, Betty, of 33 years, who joins me here today. As Johnny mentioned, her support and encouragement and advice, which I would suggest to you is virtually always correct, and her love means more to me than I could ever say. Over the past few weeks, I've met with many of you individually and have gained a real appreciation for the passion that you have for the Department of Health and Human Services. Please know that I share that passion. That's why I'm here today and why I'm honored to be the nominee for Secretary of Health and Human Services. We all come to public service in our own unique ways that inform who we are and why we serve. My first professional calling was to care for patients. That experience as a physician and later as a legislator has provided a holistic view of the complex interactions that take place every day across our communities. And today I hope to share with you how my experience has helped shape me and my understanding and appreciation for the work of the Department of Health and Human Services. From an early age, I had an interest in medicine. My earliest memories are of growing up on a farm in the state of Michigan. We lived on a farm in Michigan before we moved to suburban Detroit when I was 5 years old. I spent most of my formative years being raised by a single mom. Some of my fondest memories are spending time with my grandfather, who was a physician. When I was young, I would be able to go on, spend some weekends with him, and we'd go on rounds, which at that time meant going on house calls. And so we'd drive up to houses, and the memories that I have of individuals opening the door and giving him a hug and welcoming him graciously are cemented in my mind. After graduating from medical school from the University of Michigan, I moved to Atlanta, which I've called home for nearly 40 years. It's where I met my wife, where we raised our son. I did my residency at Emory University and Grady Memorial Hospital, where I would later return in my career to serve as the medical director of the orthopedic clinic. Throughout my professional career, I've treated patients in all walks of life, including so many children. And anyone who's ever treated a child knows the remarkable joy that you have when you're able to go tell the mom and dad that we have helped. We've helped save an individual, save their child, or help their child back to healthfulness. My memories of Grady are filled with the gracious comments of parents and of patients for the team of healthcare specialists with whom I had the privilege of working. After 25 years of school and training, I started a solo orthopedic practice. Over the years, this practice grew, as Senator Isakson mentioned, and eventually became one of the largest non-academic orthopedic groups in the country, for which I would eventually serve as chairman of the board. During 20 years as a practicing physician, I learned a good bit about not just treating patients, but about the broader healthcare system and where it intersects with government. A couple of vivid memories stand out. One, many of my patients were never more irritated or angry when they recognized that there was somebody else in the exam room, not physically, but figuratively, who was getting between the doctor and the patient in making decisions, whether it was the insurance company or government. And then there was the day when I noticed in my office, it was in the mid-90s, when I realized that there were more individuals behind the door where the clinical work was going on seeing patients than there were in front of the door. And those folks were filling out forms and making certain that we were checking all the boxes and either challenging or arguing with insurance companies or government about what was in the best interest of the patient. And it became clear to me that our healthcare system was losing focus on its #1 priority, and that is the patient. As a result, I felt compelled to broaden my role in public service and help solve the issues harming the delivery of medicine, and so I ran for the Georgia State Senate. I found the State Senate in Georgia to be often remarkably bipartisan, and that collegial relationships were the norm. This is the environment in which I learned to legislate, reaching across the aisle to get work done. In Congress, I've been fortunate as well to be part of collaborations that broke through party lines to solve problems. Just this past Congress, it was a bipartisan effort that succeeded in ridding Medicare of a broken physician payment system, and which has now begun the creation of a new system which, if implemented properly, will help ensure that seniors have better access to higher quality care. So if confirmed, my obligation will be to carry to the Department of Health and Human Services both an appreciation for bipartisan team-driven policymaking and what has been a lifetime commitment to improving the health and well-being of the American people. That commitment extends to what I call the 6 principles of health care: affordability, accessibility, quality, responsiveness, innovation, and choices. But Health and Human Services is more than health care. There are real heroes at this department doing incredible work to keep our food safe, to develop new drugs and treatment options, driven by scientists conducting truly remarkable research. There are heroes among the talented, dedicated men and women working to provide critical social services, helping families, and particularly children, have a higher quality of living and the opportunity to rise up and achieve their American dream. The role of Health and Human Services in improving lives means it must carry out its responsibilities with compassion. It also must be efficient and effective and accountable, as well as willing to work with those in communities already doing incredible work on behalf of their citizens. Across the spectrum of issues and services that this department handles, there endures a promise that has been made to the American people. We must strengthen our resolve to keep the promises our society has made to our senior citizens and to those who are most in need of care and support. That means saving and strengthening and securing Medicare for today's beneficiaries and future generations. It means ensuring that our nation's Medicaid population has access to the highest quality care. It means maintaining and expanding America's leading role in medical innovation and the treatment and eradication of disease. I share your passion for these issues, having spent my life in service to them. And yet there's no doubt that we don't all agree on or share the same point of view when it comes to addressing every one of these issues. Our approaches to policies may differ, but surely, there exists a common commitment to public service and to compassion for those that we serve. We all hope that we can help improve the lives of the American people, to help heal individuals and whole communities. So with a healthy dose of humility and an appreciation for the scope of the challenges before us, with your assistance and with God's will, we can make it happen. And I look forward to working with you to do just that. Mr. Chairman, I thank you for the opportunity to be with you today.
Thank you, Dr. Price. And we'll now begin a round of 7-minute questions, and I'll start the questioning. I'd like to talk about the Affordable Care Act and the health care system. My belief is that the historic mistake in passage of the Affordable Care Act was it sought to expand a system that already cost too much, a health care system. What is our goal here of those who want to repair the damage of Obamacare and replace parts of it? Is it to lower the cost of insurance for Americans? Is it to give them more choices of that lower cost insurance? And is it to put more decisions in the hands of states and into the hands of patients?
Yeah, thank you, Mr. Chairman. I think certainly the issues that you raise with choices and access and cost are at the heart and the center of where we ought to be putting our attention. As I mentioned in the 6 principles that I have for health care, affordability is incredibly important. It doesn't do you any good if you can't afford health coverage. Accessibility is absolutely imperative. If you have, today many folks have coverage, but they don't have care because they don't have access to the physicians that they'd like to see. So choices are absolutely vital.
Well, isn't one of the primary means for achieving those choices moving more health care decisions out of Washington, putting them back in the hands of states and patient consumers?
I think in many instances, the closer that you can have those decisions to the patient, keeping the focus on the patient, the better.
And if the responsibilities are headed toward the states, or some responsibilities, would that not necessarily involve a fair amount of extensive consultation with governors and state insurance departments about how to do that and what the implementation schedule ought to be?
Absolutely. Folks at the state level, as you well know, having served there, know their populations better than we can know them.
Senator McConnell said last week that Obamacare would be replaced and repealed in manageable pieces. I want to suggest some pieces to you on a chart back here. There looks to me like there are 4 major areas where Americans get our health care insurance. One is Medicare, 18% of Americans. One is employer insurance, 61% of Americans get their insurance on the job. One's Medicaid, and one is, which is 22%, and one is the individual market, only 6%. And the exchanges we hear so much about are just 4% of that 6%, but that's where so much of the turmoil is. Let me ask you this. Is this the bill, any effort to replace and repeal Obamacare, is this the bill to reform Medicare?
Absolutely not.
So we would be focused on employer, Medicaid, and individual insurance. Are those accurate categories, or would you categorize them in a different way?
I think the challenges that we have to address immediately are those in the individual market and in the Medicaid market, as you identify.
Mm-hmm. And is it possible to work on one of those areas at a time rather than in a comprehensive, or let me put it this way, I said that don't expect Senator McConnell to wheel in a wheelbarrow with a big comprehensive Republican health care plan. That's because, in my opinion, we don't believe in that. We don't believe in replacing a failed Washington, D.C. health care plan with our own failed plan. We want to work on it step by step, large piece by piece. Is that how do you respond to that?
I think that's fair. I think that for individuals the American people need to appreciate that the last thing we want to do is go from a Democrat health care system to a Republican health care system. Our goal would be to go from what we see as a Democrat health care system to an American health care system that recognizes the needs of all.
Now, I know your plan won't be presented until after you're confirmed, but the president-elect has said, let's do repeal and replace simultaneously. To me, that must mean that any repeal of parts of Obamacare wouldn't take effect until after some concrete, practical alternative were in place for Americans to choose. Is that accurate, or do you have a different idea of what simultaneous might mean or what the sequencing might be as we move through this process?
No, I think that's fair. I think one of the important things that we need to convey to the American people is that nobody's interested in pulling the rug out from under anybody. We believe that it's absolutely imperative that individuals that have health coverage be able to keep health coverage and move, hopefully, to greater choices and opportunities for them to gain the kind of coverage that they want for themselves and for their family. So I think there's been a lot of talk about individuals losing health coverage. That is not our goal, nor is it our desire, nor is it our plan.
Let me ask you about how long this might all take, this repairing the damage, this working on these 3 big areas individual market, Medicaid, and employer. My sense of it is that we've been working on this so long, although we have different opinions about it, we ought to be able to make most of our votes in the next few months about what to do, but that the implementation of whatever we decide, especially since it will be going, some of it back to the states, to the department that you hope to lead, might take several years. Is there a difference between the votes we might take and then a longer time for implementation of what we decide to do?
No, I think that's fair. I would point out that our healthcare system is continually evolving, and should. We ought to be always looking at how it's working, whether it's working for patients, whether it's working for the individuals that are working to provide the highest quality care for folks. And when it is, that's fine. When it isn't, then it's incumbent upon policymakers to make certain that we do the kinds of things to adjust that policy so that it can work, especially for patients.
My last question is about this individual market, the 6%. The Obamacare exchanges are about 4% of all of us who have insurance. Our insurance commissioner in Tennessee says the market is virtually collapsing. I'm told by many people that we need to basically have a rescue plan, a reform plan for the individual market in place by March the 1st, so that insurance companies who make their decisions about the year 2018 can make those plans so that people have insurance to buy in all of these states. Do you agree that the market is collapsing, that we need a rescue plan, and that March the 1st is an important approximate date for a decision of action?
Well, we're clearly seeing changes in the individual and small group market that are adverse to the patient, whether it's decreasing access to coverage, whether it's increasing premiums, whether it's higher deductibles. Something is going badly wrong out there, and it's imperative, I believe, for us to recognize that and then to put in place the kinds of solutions that we believe to be most appropriate.
And your plan that we're likely to see in February will include recommendations for how to do that?
We look forward to, should I be given the honor of leading it, Health and Human Services, along with the President, we look forward to working with Congress to come forward with that plan.
Thank you, Dr. Price. Senator Murray.
Thank you, Mr. Chairman. Before I start, I want to ask consent to put a letter to Chairman Alexander from all 11 Democrats on this committee on the importance of a second round of questions on this nominee. And I ask unanimous consent to put in the record 25 letters signed by 193 organizations opposing Congressman Price's nomination to lead the Department of Health and Human Services. And I also have a petition signed by 500,000 people from across the country opposing this nomination. I ask to put in the record.
There will be.
Congressman Price, recent press reports about your investments in the Australian biotech company Innate Immunotherapeutics raises some serious questions about your judgment, and I want to review the facts. You purchased stock in Innate Immunotherapeutics, a company working to develop new drugs, on 4 separate occasions between January 2015 and August 2016. You made the decision to purchase that stock, not a broker, yes or no?
That was a decision that I made, yes.
You were offered an opportunity to purchase stock at a lower price than was available to the general public, yes or no?
The initial purchase in January of 2015 was at the market price. The secondary purchase in June through August, September of 2016 was at a price that was available to individuals who were participating in a private placement offering.
That was lower than was available to the general public, correct?
I don't know that it was. It was the same price that everybody paid for the private placement offering.
Well, Congressman Chris Collins, who sits on President-elect Trump's transition team, is both an investor and a board member of the company. He was reportedly overheard just last week off the House floor bragging about how he had made people millionaires from a stock tip. Congressman Price, in our meeting, you informed me that you made these purchases based on conversations with Representative Collins. Is that correct?
No.
That is what you said to me in my office.
What I believe I said to you was that I learned of the company from Congressman Collins.
What I recall our conversation was that you had a conversation with Collins and then decided to purchase the stock.
No, that's not correct.
Well, that is what I remember you hearing say in my office. In that conversation, did Representative Collins tell you anything that could be considered, quote, a stock tip, yes or no?
I don't believe so, no.
Oh, well, if you're telling me he gave you information about a company, you were offered shares in the company at prices not available to the public, you bought those shares, is that not a stock tip?
Well, that's not what happened. What happened was that he mentioned, he talked about the company and the work that they were doing in trying to solve the challenge of progressive secondary multiple sclerosis, which is a very debilitating disease and one that
I'm well aware
I
of
had
that,
the opportunity to treat patients when I was in practice.
I'm aware
I
of that.
studied the company for a period of time and felt that it had some significant merit and promise, and purchased the initial shares on the stock exchange
Congressman
itself.
Price, I have very limited time. Let me go on. Your purchases occurred while the 21st Century Cures Act, which had several provisions that could impact drug developers like innate immunotherapeutics, was being negotiated. And again, just days before you were notified to prepare for a final vote on the bill. Congressman, do you believe it is appropriate for a senior member of Congress actively involved in policymaking in the health sector to repeatedly personally invest in a drug company that could benefit from those actions, yes or no?
Well, that's not what happened.
Well, let me just say that I believe it's inappropriate, and we need answers to this regarding whether you and Congressman Collins used your access to non-public information when you bought at prices that were unavailable to the public. And again,
I had no access to non-public information.
Well, we will go on. Congressman Price, just last week, you and Republicans in Congress voted to begin ripping apart our health care system, which would cause nearly 30 million people to lose their coverage and raise health care costs for families, without telling the American people specifically what you plan to do instead. President-elect Trump and Republicans in Congress have promised to deliver a plan that prevents anyone from losing coverage and leaves no one worse off. Just days ago, President-elect Trump said his plan would provide insurance for everybody. Do you share those goals?
I think it's absolutely imperative that we have a system in place that has patients at the center and allows for every single American to have the opportunity to gain access to the kind of coverage that they want.
You share his goal of insurance for everybody?
That's been always my stated goal. It's what we've worked on and throughout my entire public career.
Okay. If your repeal plan, the Empowering Patients First Act, was signed into law, would you consider these commitments to ensure all Americans and leave no one worse off be met?
The goal of the bills that I've worked on here in Congress, and understanding that the role, if I'm given the privilege of leading at HHS, is different, but my role in Congress was to always make certain that individuals had the opportunity to gain access to the kind of coverage that they desired, and that they had the financial feasibility to do so.
Okay.
That's what's different about the plans that we put forward.
All right. Well, I think it's really important that we have clear answers. So let me just say this. Your bill only allows people with pre-existing conditions to obtain health insurance if they maintained continuous insurance for 18 months prior. Millions of Americans with pre-existing health conditions lack insurance for short periods of time. Under your plan, insurance companies could deny those Americans coverage for pre-existing conditions, yes or no, under your bill?
It's a broader question than that, because we would put in place high-risk pools and individual health pools that would allow every single person in the individual small group market, who are the ones challenged with pre-existing illness, to be able to gain access again to the coverage that they want. So we believe through that plan that every single person would have the opportunity and financial feasibility to gain the coverage that they want for themselves and for their families.
We disagree on the consequences of that. Your bill would repeal dependent coverage available to young adults up to age 26. That is correct, right?
The bill that I authored did not include coverage up to age 26. The insurance companies have said that they were working that they were including that in their plans going forward, and so we felt it was covered.
Okay, and your bill takes away current benefits, which include prescription drugs, mental health and substance use disorder benefits, and maternity coverage, among others. That is correct, right?
Again, it's different in the legislative arena than it is in the administrative arena, but there are other factors that we would put in place that would make certain that individuals had the care and the kind of coverage that they needed for whatever diagnosis would befall them.
Again, I disagree with the consequences, but your bill didn't cover that. Your bill also repeals the lifetime limits on coverage that helps a lot of people who are sick and have high medical expenses, like a person with cancer. Yes or no?
Well, again, it's a larger question, because what we would put is a different construct in place that would allow for every single person to gain access to the coverage that they want and have nobody fall through the cracks.
Well, I think just with these questions. I'm very concerned that your vision for a health care system is very different than one that I think millions of Americans are counting on.
Thank you, Senator Murray. Senator Enzi.
Thank you, Mr. Chairman, and thank you, Dr. Price, for being willing to serve and to go through this process. I call this gotcha management. Nothing is barred, and the idea is to get you to take questions on short notice in public that you wouldn't have done what you normally do. I've worked with you for the last 2 years, meeting with you at least once a week, every week that we've been in session. So I know how you operate, and I appreciate how you operate, and the care and the focus and the concern and how comprehensively you think about particularly the medical things. One of my concerns is always the rural areas, because Wyoming is the most rural state in the nation. I hesitate to do that because last night at the education hearing, I got to hear from Mrs. DeVos, who remembered a conversation from a month before that I had on a rural problem, which dealt with grizzly bears by the Wapiti School in Wyoming. And that became a major topic around here, and I'm glad everybody recognizes that need and concern. Now, part of the story was that that's the grade school that former Senator Craig Thomas went to, and when he was there, they didn't need that fence because he was tough. But there are different kinds of problems in different places in the healthcare area. I have a county that's the size of Delaware. It has one community that would like to say that it has 2,500 people. It does have a hospital, but when you have a rural community, a rural county that big, with that small of a town, it's difficult to keep a doctor. Without at least a PA there, the hospital has to close. And if that hospital closes, emergency care is 80 miles away. Not a likely story in most of the places, and we need to make sure that those things are covered. And I've appreciated getting to share those with you over the period of time. I was always curious as to why you left a very successful practice and were willing to come back here and try to make a difference, and I want to congratulate you on the difference that you have made. Now, one of the questions I'd ask you is, why are you willing to leave a place with so much responsibility and background and capability to be willing to be the Secretary of Health and Human Services?
Thank you, Senator. When I think about the mission of the Department of Health and Human Services, which is to improve the health, safety, and well-being of the American people, it's what I've literally spent my life trying to do. And so to have the opportunity to participate, if confirmed, to serve as the Secretary of Health and Human Services and try to guide that organization in a direction that would further fulfill that mission, I can't think of anything more exciting or fulfilling.
Well, and I think you have the background for doing that, too, with the wide range of experience you had between the different practices and hospitals, and then coming here and going through a number of different committee situations. But what you're about to go through is rather intense, and then that's followed by probably the most productive part if senators happen to read the answers, and that's that we get to do written questions as well, which we hope you'll provide a rapid response on. But those aren't nearly as much fun for the panelists because they aren't in public. I'll move to some questions that are a little bit more related here. Because we begin serious and challenging task of restoring these health insurance markets, which are teetering on the brink now. Some are collapsing. Some counties you can't get coverage. In Wyoming, there's only one provider. And it's my understanding that the incoming administration may have the ability to make some key policy changes immediately. Some of the most critical changes for short-term stabilization of the markets might include reducing the number of special enrollment periods and requiring upfront verification, or aligning grace periods for non-payment of premiums with state law. My understanding from those in the insurance business is that some targeted actions by the Department of Health and Human Services may provide some meaningful changes that could impact premiums for the next year. Are those some options that you might consider?
Absolutely. The insurers, as I think the chairman mentioned, are deciding right now, as they come forward in March and April, what the premium levels will be for 2018, calendar year 2018. What they need to hear from all of us, I believe, is a level of support and stability in the market, the kinds of things that make it so that they're able to provide product to patients out there. You mentioned that there are counties in your state where there's only one provider. There are 5 states in this nation where there's only one insurance provider. There are 1/3 of the counties in this country only have one insurance provider. We must, as policymakers and as folks administering these programs, we must ask ourselves, what's going on? Where are the problems out there? That may work for the insurers in certain instances. It may work for government, but it doesn't work for patients. And so if we keep the patients at the center of all of this, we'll get to the right answer, and that's what I hope to do with each and every one of you.
I appreciate that, and I got to work for years with Senator Kennedy on biologics and biosimilars, and having the requirements for their biosimilarity and interchangeability has needed some additional information. The FDA has issued guidance documents since the law passed, but they haven't set policy on interchangeability with a reference product. I was concerned that in 2017, having gone through nearly 2 full presidential terms, that just yesterday we finally got a draft of the FDA's interchangeability policy. I'll ask that question since my time has expired in writing. Thank you.
Thank you very much, Senator.
Thank you, Senator Enzi. Senator Sanders.
Thank you, Mr. Chairman, and Congressman Price, thanks for being here, and thanks for the conversation we had the other day.
Thank you.
Congressman, on May 7, 2015, well, let me begin by saying all of us know that we have come through a very unusual election process. President-elect Trump received almost 3 million votes less than Secretary Clinton, but he won the Electoral College. He's going to be inaugurated this week. He won a number of states by rather slim margins. During the course of his campaign, Mr. Trump said over and over again that he would not cut Social Security, not cut Medicare, not cut Medicaid. Let me read some quotes. On May 7, 2015, Mr. Trump tweeted, "I was the first and only potential GOP candidate to state there will be no cuts to Social Security, Medicare, and Medicaid." On April 18, 2015, he said, quote, "Every Republican wants to do a big number on Social Security. They want to do it on Medicare. They want to do it on Medicaid, and we can't do that. And it's not fair to the people that have been paying in for years, and now all of a sudden they want to be cut," end of quote. August 10, 2015, Mr. Trump said, quote, "I will save Medicare, Medicaid, and Social Security without cuts. We have to do it. People have been paying in for years, and now many of these candidates want to cut it," end quote. March 29, 2016, Trump said, "You know, Paul Ryan wants to knock out Social Security, knock it down, way down. He wants to knock Medicare way down. And frankly, well, 2 things. Number 1, you're going to lose the election if you're going to do that. I'm not going to cut it, and I'm not going to raise ages, and I'm not going to do all of the things they want to do. But they want to really cut it, and they want to cut it very substantially, the Republicans. And I'm not going to do that," on and on and on. Point being, this is not something he said in passing. I think it is likely he won the election because millions of working-class people and senior citizens heard him say he was not going to cut Social Security, Medicare, and Medicaid. Congressman Price, a very simple question. Is the President-elect, Mr. Trump, going to keep his word to the American people and not cut Social Security, Medicare, and Medicaid, or did he lie to the American people?
I haven't had extensive discussions with him about the comments that he made, but I have no reason to believe that he's changed his position.
All right, so you are telling us that to the best of your knowledge, Mr. Trump will not cut Social Security, Medicare, and Medicaid.
As I say, I have no reason to believe that that position has changed.
Congressman Price, quoting Mr. Trump again, or at least paraphrasing him, just last week he said, roughly speaking, pharma is getting away with murder. You recall that tweet?
I do.
Okay. There are many of us on this side of the aisle who are working on legislation that would do at least two things. Number one, end the absurdity of the American people being ripped off by the pharmaceutical industry, who 2 years ago made top 5 companies made $50 billion in profits, while 1 out of 5 Americans can't afford to fill the prescriptions their doctors write. Will you and will the President-elect join us in legislation we are working on, which, number one, will allow Medicare to negotiate prices with the drug companies and lower prices, and number two, allow the American people to bring in less expensive medicine from Canada and other countries? Is that something you will work with us on?
The issue of drug pricing and drug costs is one of great concern to all Americans. I think it's important to appreciate that in a couple areas we've had significant success, whether it's in the generic area where costs are significantly less than they have been, and in part...
But you are aware, sir, I don't mean to be... we don't have a lot of time. We are paying by far the highest prices in the world for prescription drugs. You don't disagree with that, do you? Do you disagree with that?
I think that's the case. I'd have to look at the statistics. I think there are a lot of reasons for that, and if we get to the root cause of what that is, then I think we can actually solve it in a bipartisan way.
One of the root causes is that every other major country on earth negotiates drug prices with the pharmaceutical industry. In our country, the drug companies can raise their prices. Today, they could double their prices. There is no law to prevent them from doing that. Will you work with us so that Medicare negotiates prices with the pharmaceutical industry?
You have my commitment to work with you and others to make certain that the drug pricing is reasonable and that individuals across this land have access to the medications that they need.
Wasn't quite the answer to the question that I asked. Congressman Price, the United States of America is the only major country on earth that does not guarantee health care to all people as a right. Canada does it. Every major country in Europe does it. Do you believe that health care is a right of all Americans, whether they're rich or they're poor? Should people, because they are Americans, be able to go to the doctor when they need to, be able to go into a hospital because they are Americans?
Yes, we're a compassionate society.
No, we are not a compassionate society. In terms of our relationship to poor and working people, our record is worse than virtually any other country on earth. We have the highest rate of childhood poverty of any other major country on earth, and half of our senior older workers have nothing set aside for retirement. So I don't think compared to other countries we are particularly compassionate. But my question is, in Canada, in other countries, all people have the right to get health care. Do you believe we should move in that direction?
If you want to talk about other countries' health care systems, there are consequences to the decisions that they've made, just as there are consequences to the decision that we've made. I believe, and I look forward to working with you to make certain that every single American has access to the highest quality care and coverage that is possible.
Has access to does not mean that they are guaranteed health care. I have access to buying a $10 million home. I don't have the money to do that.
And that's why we believe it's appropriate to put in place a system that gives every person the financial feasibility to be able to purchase the coverage that they want for themselves and for their family. Again, not what the government forces them to buy.
Yeah, but if they don't have any, well, that's a longer story. Thank you very much.
Thank you.
Thank you, Senator Sanders. Senator Hatch.
Well, thank you, Mr. Chairman. Welcome to the committee. Having worked with you over the years, I've found you to be always very, very knowledgeable.
Thank you.
Very upfront. Very straightforward, very honest, and somebody who really understands the healthcare system of this country. And you're just perfectly situated to be able to help turn it around and get it so it works. We hear a lot from our other side about how bad the system is and so forth, and I've got to tell you, I don't think it's very good myself. And we've got to work on it and get it done right, but boy, I'd sure like to have you right there helping to get it done. because you're one of the really premier people in this whole Congress and in the world, as a matter of fact, understanding what needs to be done and yet recognizing the problems of getting it done. Now, Dr. Price, some of my colleagues have criticized you for your health-related stock holdings while serving in the House. Now, not only do House rules not prohibit members from trading stocks, but it is also not an uncommon practice for members of Congress. In fact, there are members on this committee who have, as I understand it, who have traded individual health stocks while serving on this committee. Now, this appears to be nothing more than a hypocritical attack on your good character. And I personally resent it, because you have always disclosed. But let me just say this. Can you confirm that you have always followed the law relating to trading in stocks while serving as a member of Congress?
Thank you, sir. Everything that we have done has been above board, transparent, ethical, and legal. And as you know, and the members of this committee know, there's an organization that's called the Office of Government Ethics that looks at all of for every cabinet nominee, looks at all of the possessions, all the holdings, and the like, and makes a recommendation as to what that cabinet member must do in order to make certain that there's no conflict of interest. The Office of Government Ethics has looked at our holdings and given advice about what would need to be done in terms of divesting from certain stock holdings to make certain that there's no conflict of interest. We have read those and agreed to those, signed those. That document is online for everybody to see so that everybody is absolutely certain that there will be no conflict of interest whatsoever.
Well, thank you. And you followed their advice.
Absolutely.
Well, Dr. Price, the collapse of Obamacare has exacerbated our nation's health care problems. Too frequently, my colleagues and I have seen European idealism strangle functional insurance design with cost-prohibitive measures. And despite these failed reforms, I don't think we can lose sight of the broader health system that is at risk. For example, rare disease patients do not have access to life-saving treatments because policies that stem from Obamacare prevent investments in innovative therapies that can cure and save lives. Now, this is an issue that I'm deeply passionate about. Dr. Price, what steps do you believe will improve the pipeline for rare disease therapies to bring treatments and cures to patients in desperate need of hope?
Well, the Orphan Drug Act, which passed, I think, 30 years ago or so, was
my
really
first bill, by the way.
And it really has revolutionized the ability to treat rare diseases. And what it did is make the United States the leader in coming forward with treatments for rare diseases. And I think that there are things that we can do in terms of patent protection, in terms of liability, in terms of incentivization, resources to be able to encourage the discovery of cures for rare diseases.
And we have a lot more drugs coming through, and even some blockbuster drugs that came because of that little bill.
Yes.
We just put some incentives in effect, and all of a sudden there's an explosion in orphan drugs for population groups of less than 200,000 people. It's a pretty important little bill. It
One of the
cost a lot of money, but it was a Republican bill.
Yeah. One of the success stories, truly, for public policy in the country.
Right. Now, Dr. Price, one of the central duties of the HHS Secretary is to be diligent and thoughtful when considering if federal regulation is necessary and assessing whether the regulations impede research, development, and innovation. Over the years, the regulatory infrastructure guiding dietary supplements has changed dramatically. Do you recognize the importance of dietary supplements in helping Americans reach and maintain healthy lifestyles?
Absolutely.
And will you commit to me and other members of the committee to work to ensure appropriate regulation and implementation of the Dietary Supplement Health and Education Act so that we can protect public health while assuring consumers continued access to safe products?
Yeah, this is one of those areas where it's incredibly important to gain the information that you referred to gather the individuals that know the most about this area, whether it's consumers, whether it's those providing the product to market, make certain that there are protections for unadulterated products. But it's absolutely vital that we get this right.
Well, I'll tell you this. I have to commend Donald Trump for picking you.
Thank you.
You're clearly one of the premier people in all of Congress who understands the problems of health care. and you have the professional background that I don't know any other member of Congress can match to help solve the problems that we have. We've got a real messy situation here, and Obamacare has not really helped. Do you think Obamacare has helped?
I think that some of the things that have occurred with the passage of the ACA have improved certain areas. The coverage is certainly improved. But the consequences of that, I mean, that many people, as I mentioned before, have coverage, but they don't have care. So there's so many things about just the decision-making process. Who decides about our health care? Should it be the federal government, or should it be patients and families and doctors? And we certainly believe the latter as opposed to the former.
I take it that you believe that getting health care closer to the people is a far better thing than everybody pontificating from Washington, D.C.
I think the more involvement that patients and families and doctors can have in medical decisions, the higher quality care we'll have.
In my earlier life, I was one of the things I did was I was a medical liability defense lawyer, defending doctors, hospitals, nurses, healthcare providers, etc. What do you think we should do about medical liability?
This is really a difficult challenge, because it's not just the malpractice rates that doctors or hospitals pay, but it's the practice of defensive medicine, which are the things that physicians do that don't hurt anybody, but they're tests and procedures and examinations that aren't necessarily needed to either make a diagnosis or to treat the patient.
But show up in their history.
But it shows up in their history, so that if they're called into a court of law, they can say to the judge and the jury, I don't know what you wanted me to do because I did everything. When in fact everything is rarely necessary to either treat or to diagnose the patient. So if we look at it in that light and try to focus on decreasing the practice of defensive medicine to the benefit of patients, then I think we can get to the right answer, and there's some exciting opportunities out there that have been bipartisan in the past.
Well, thank you, sir. I think you're a great nomination.
Thank you.
Thank you, Senator Hatch. Senator Casey.
Thank you, Mr. Chairman. Representative Price, we're grateful you're here, and thanks for the visit to our office.
Thank you.
And I wanted to highlight something we probably don't spend enough time highlighting or talking about, and that's the full protections of what was known as the original bill, the Patient Protection and Affordable Care Act. We've had a lot of shorthand terminology since then. And I know you and I have a basic disagreement. I think it's important to be candid about that. But I think what a lot of people have forgotten about is that, the chairman had a chart earlier that outlined the categories of Americans that have health insurance by virtue of various programs, or I think the number he had on that poster about the number of Americans in the employer-sponsored coverage category, I think it was 178 million people. That's a lot of folks with coverage who had coverage before. Most of them, I guess, would have had coverage before the legislation and after, meaning they were paying their premiums and had coverage, but they didn't have protections that only came with the passage of the legislation. We know that somewhere between 11 and 12 million people have purchased health insurance through the individual marketplace. And so I want to ask you a couple of questions about those basic protections that are now law that were not law before. I think you'd agree with me, and you know from your practice, that you meet just remarkably inspiring people in your work, and once in a while here in the Senate we do as well. Probably don't take enough time to have those opportunities. But one of the people I met in the lead up to the legislation passing was Stacy Ritter. She was from Manheim, Pennsylvania. She didn't have a personal challenge. It was the challenge faced by her two daughters. They were 4 years old, Madeline and Hannah. And as she said, as Stacy said about her daughters, she said that they would be, at that time, before the passage of the bill, punished and rejected because they had the misfortune of developing cancer as a child. And her basic problem was the caps on treatment. So the first question I'd ask you in terms of your work as Secretary of Health and Human Services, should you be confirmed, would be, will you commit to maintaining the protections that ensure that no child is denied insurance coverage because of pre-existing conditions?
Well, I think that pediatric cancer is one of those things that is remarkably challenging. I remember when I was in my residency and did a rotation on the pediatric orthopedic ward, and so many of those children had cancer. And before I began that rotation, I almost dreaded going to that month because I was worried about just the severity of the challenges that I would meet. I'll tell you, it was one of the most uplifting months I spent in medical school, and that was because the children were so uplifting. And so absolutely we need to make certain that every single child has access to the kind of coverage that they need and the care that they need. And there are a number of ways to do that, and I look forward to working with you to make that happen.
I heard the word yes there. Secondly, and it's really hard to believe that we even have to ask a question about this next topic, which is victims of domestic violence. It was the state of the law prior to the passage of the legislation that victims of domestic violence were considered Americans who had a pre-existing condition. It's still the law in some states that they are not protected. So question number 2 is, will you commit to maintaining the protections that ensure that victims of domestic violence will not be discriminated against when purchasing health insurance? Yes or no?
Yeah, I think it's absolutely vital that victims of domestic violence and others, anybody, we need a system in place that ensures that individuals are either not priced out of the market because they get a bad diagnosis, or not eligible or able to purchase coverage that works for them because of their diagnosis.
In limited time, I want to interrupt. I don't want to get hung up on priced out of the market. What I'm asking for is an ironclad guarantee that circumstance, that horrific circumstance, will never be a bar to coverage, treatment, or care.
Well, it certainly shouldn't be, and as you well know, if I'm fortunate to be confirmed, that's an administrative role, and it's the policy decision that the legislators would make.
Well, I think we can agree on that. Number 3, will you maintain to committing the protections that prohibits discrimination in health insurance on the basis of health status or disability? Yes or no?
Again, I think it's absolutely imperative that we have a system in place that works for patients, and anybody not being able to gain access to the coverage that they want or need is not a system that works for patients.
And I'll follow up with more questions. What I'm getting at here is that we had a state of the law before passage of the ACA where individuals like that, whether they happen to have a child had a pre-existing condition, even if their parents were paying premiums for years, an insurance company could literally say, sorry, you have a pre-existing condition, or your child does, you can't get coverage. Women were discriminated against because they were women. Just a remarkable stain on America that we allowed that to happen. My concern, though, now is not just a series of concerns about what you've proposed as a member of the House and what you could do as Secretary, but I just heard earlier that the 3 areas that will be of focus in whatever replacement plan there is, and I'm anxious to see it, would be, and I wrote them down, I think Chairman Alexander wanted to take off the table, and that's a good thing, Medicare. But I heard that there'll be 3 targets. That's my word, of course. The individual market, Medicaid, and employer-sponsored coverage. So I hope if employer-sponsored coverage is a subject of change, that will ensure all those protections that are in place right now. And that's why I'm asking those questions. I'll follow up more in writing, or if we get another round. And Mr. Chairman, put me on record as incorporating by reference everything Ranking Member Murray said about questions and an additional round. Thank you.
Thank you, Senator.
Thank you, Senator Casey. Duly noted, and I appreciate you using your 7 minutes to ask questions. Senator Isakson has deferred to Senator Paul.
As a fellow physician, and as a fellow physician who did some of my training at Grady, congratulations. And I wish everybody on the committee could come to Grady and see you working there, see what it's like to work in one of our nation's biggest charity hospitals, often doing work that is just incredible. Gunshot wounds, compound fractures of the femur, you name it. And I remember being there as a student and then as an intern some, and we used to always calculate how many hours and divide by our income and say, boy, we wish we could get minimum wage. But I think it is important that we get somebody with that kind of clear reasoning and critical skills, to be in charge of our government, both knowing about the medical aspect as well as, the public policy aspect. I think what I regret about this kind of hearing and sort of, I think what a lot of people in America regret about is sort of the vitriol and the rancor and the partisanship that should go into something that we kind of all want the same things. And to question your motives, I think, is insulting. To question whether you're honest is insulting. The whole question of, and I guess this would be my first question to you, did you go into public service to enrich yourself or for public service?
I have a passion for public service and a passion for people, and that's what guided our decision that some might think was a foolish decision for both of us to.
Did you take a pay cut to go into public service?
I didn't consider the remuneration for public service.
Right, but I'm guessing it would have been a pay cut. The motives as to what we should do, see, I think we aren't separated that much on our motives. I think we all want the most amount of insurance for people at the least amount of cost. We want, people to get access to health care. What are your motives? What are your goals? What should we do with the health care system? Do you want more people to be insured? Do you want more people to have health care? Or do you think we disagree just on how we do it and not necessarily the motives?
No, as I tried to lay out earlier, and I know time is short for everybody, but the principles that I think are absolutely imperative for a healthcare system is one that's affordable for everybody, one that provides access to health care and coverage for everybody, one is that's of the highest quality, that is responsive to patients. System isn't any good if it's not responding to patients. One that incentivizes innovation, because it's the innovation that drives the high quality health care, and then one that ensures choices are made and preserved by patients. So patients ought to be the ones choosing who's treating them where, when, and the like.
You and us by extension, Republicans by extension, have been accused of having no replacement ideas, no ideas for how to fix the system. Approximately how many bills do you have that could be regarded as replacement bills or ways to improve the health insurance system in our health care?
We've had one large-term bill since March or early 2009, and then beyond that, tens of pieces of legislation to address the health care issue.
It's also been insinuated that America is this horrible, rotten place, that we don't have compassion, and I guess by extension the physicians don't. Well, as you worked as an emergency room physician or as you worked as a physician, did you always agree as part of your engagement with the hospital to treat all comers regardless of whether they had an ability to pay?
It's one of the things we pride ourselves upon, and that is that anybody that showed up in need of care was provided that care, and that was true not only in our residency but in our private orthopedic practice as well.
And it's interesting that those who say we have no compassion, extol the virtues of socialism. And you look at a country like Venezuela with great resources and an utter disaster where people can't eat, devolving into violence. And, I think it is important that we do have a debate ultimately in our country between socialism and communism and America and capitalism. One of the things that's extraordinary about our country is that just 2 years ago, in 2014, we gave away $400 billion privately, not the government, individually to your churches and to charities. We're an incredibly compassionate society, and I think often this was misplaced in sort of the wonky numbers of this number and that number within healthcare. How much we do help each other. Not only do we help each other in our country, I'll bet you half the physicians in my community in Bowling Green have gone on international trips and done international charity work. And all that is lost in saying that we're this heartless, terrible country. And I would just argue the opposite. I think the greatness of our country and the greatness of the compassion of our country, we give away more than the gross domestic product of most of these socialized countries around the world. So I think it is important. With regard to replacement, a couple of things. There are some big, broad ideas that I think would ensure more people. One is the idea of legalizing the sale of all types of insurance. Under Obamacare, we made it illegal to sell certain types of inexpensive insurance. Do you think we could insure more people and help some of the people who actually don't get insurance under Obamacare to get insurance if we would legalize the sale of more types of insurance?
I think choices, as I mentioned, is absolutely vital, and I know that if we have as a principle and as a goal having patients have those choices, then I believe that patients will select the kind of coverage that they want. The choices that ought to be available to them are a full array of opportunities.
You think health savings accounts will help also some people that are not helped currently?
I think health savings accounts and high deductible catastrophic coverage are things that make a whole lot of sense for many individuals, and we ought not force anybody to do anything. It ought to be a voluntary choice, but they ought to have the choice to be able to select them.
And one of the things you've had different legislation on, and I'm a big supporter of, is allowing individuals to join together in groups to buy insurance. Do you think this has a possibility of what Senator Alexander talked about, the millions of people in the individual market? I have great sympathy for that. I was a small physician with 4 employees, and if one employee were to get sick, it could be devastating to not only to them but also to the economics of keeping them employed. But letting us join together into pools where instead of me buying insurance as one of 4 people, I could buy it in a big group, maybe 100,000 people, maybe 1 million people. And currently the laws kind of prevent that, but you had some bills for expanding that, and I'm a big fan of that. Could you mention some of the association health plans and how that might help some people to get insurance who don't have insurance currently?
Yeah. Thank you. Association health plans are one of those entities that would allow individuals who are economically aligned in some way to be able to purchase coverage together, even though they don't necessarily work together or in the same group. Individual health pools, which I think is one of the secrets to being able to solve the individual and small group market conundrum that we find ourselves in, would allow anybody to pool with anybody else solely for the purpose of purchasing health coverage. It's not a new idea. The model for it is actually the Blue Shield plan that existed decades ago that allowed people to pool their resources together for major medical coverage for hospitalization. And it just makes a lot of sense. It allows insurance to work the way it's supposed to work, which is to spread the risk, and then anybody's adverse health status doesn't drive up the cost for them or anybody else because the pool is large enough.
Thank you, Senator Paul. Senator Franken.
I'll tell you how we get a really big risk pool. It'd be called Medicare for Everyone. That would be the biggest risk pool. Dr. Price, it was nice meeting you the other day.
That was good.
Did you enjoy meeting me?
Thank you. I did. I did. I enjoyed our discussion about our gray hair.
Yeah. Dr. Price, what is the leading cause of preventable death in the United States?
I'll defer to you. You've obviously got it on the page in front of you.
I actually knew this before I put it on the page. It's smoking.
Well, that hits home. I lost my dad, who was a Lucky Strike smoker from World War II to emphysema, and he prided himself on the fact that he never smoked a cigarette with a filter for years and years, and it was incredible tragedy.
I lost my dad too.
Yeah.
As a physician, you may know, I guess you didn't, that smoking kills approximately 480,000 Americans each year and totals $170 billion each year in healthcare costs. And yet, between 1993 and 2012, you were a shareholder of tobacco, of big tobacco companies, meaning that you personally benefited from tobacco sales. Meanwhile, you voted against landmark legislation in 2009 that gave the FDA the authority to regulate tobacco. Congressman Price, you're a physician, which means you took the Hippocratic Oath, a pledge to do no harm. How do you square reaping personal financial gain from the sales of an addictive product that kills millions of Americans every decade with also voting against measures to reduce the death toll inflicted by tobacco?
Well, it's an interesting question, Senator, and it's a curious observation. I have no idea what stocks I held in the 90s or the 2000s or even now. All of these decisions for all of us, I suspect, are through mutual funds and through through pension plans. I would bet, and I don't want, well, I ought not bet here. I would suspect that in your pension plan that there are components of that that are held that may have something to do in some time in your history with tobacco. So
I find it very hard to believe that you did not know that you had tobacco stocks. I find it a little hard to believe that in the questions about your stock portfolio, you've said you didn't know things. Just over the last 4 years, you traded more than $300,000 in health-related stocks, while at the same time sponsoring and advocating legislation that could affect the performance of those stocks. Now, we've talked a little bit about the Zimmer Biomet. Your broker, you say, you didn't know this, bought it on March 17, 2016. You did introduce a bill later, a week later, on March 23, 2016. You say that you did not know then that you had this stock. It was a rule it was to delay a federal rule that would have reduced the profitability of the company's joint, to delay a rule that would hurt the company. What I don't understand is once you found out that your broker bought it, you kept the stock. You purchased this $50,000 to $100,000 worth of stock in a biomedical company called Innate Immuno. We've talked about it a little bit. It's the single largest purchase in the past 3 years in a private deal that was not made available to the public. And I find it absolutely amazing that you responded that you did not know that you got a discounted price. That is absolutely amazing because we discussed this.
Well, by definition, I believe that's the nature of a private placement offering. What I said to you and what I've said to others is that I paid exactly the same price as everybody else. I disclosed it.
It was a private offering that only went to about 20 people, including Representative, your colleague, Chris Collins, his chief of staff, and a prominent D.C. lobbyist. And you reported $50,000 to $100,000 in profits on this purchase. It really begs credulity, sir, when you say you did not know that you got a discount on this. This was a private offering to a very small number. When you have the committee, chairman of the budget committee, when you have a congressman as chief of staff, these sound like sweetheart deals, and I think that our job in this body and in Congress and in government is to avoid the appearance of conflict. And boy, you have not done this. I want to talk just about your latest plan, Empowering Patients First Act. Some of it is detailed in this article from the New England Journal of Medicine. It's called Care for the Vulnerable versus Cash for the Powerful, Trump's Pick for HHS. I'll just read a random paragraph. Price's record demonstrates less concern for the sick, the poor, and the health of the public, and much greater concern for the economic well-being of their physician caregivers. And I would commend this to every member of this committee before making a vote, because what your plan does is, one of the things, it gives a tax credit to Americans to buy health insurance. It's no different for someone who's poor or someone who makes $20,000, $30,000, and to Bill Gates. It is an incredibly regressive system. You have talked about ending you guys want to end the expansion of Medicaid. That has people in Minnesota scared out of their mind. Look, I've heard a lot, Obamacare has been a disaster. First of all, you have to admit that it's bent the cost curve, that the cost of health care in this country has grown less than it did in the previous 10 years. It's also covered 20 million more people, but forget them. You know, in 2008, I would go around the state of Minnesota in every VFW hall, in every cafe, I would see a bulletin board where it would have a burger bash or a spaghetti dinner for someone who had gone bankrupt because they had gone through their annual cap or their lifetime cap. I am very frightened about what you are going to do, and so are millions of Americans. And frankly, I know that you do things that help, that physician groups, you've put in provisions that would prevent these findings by efficiency and innovation boards that would have to be cleared by physician groups. I see you as someone who is there for the doctor, and that this is a cover for, this is not going to create access for all Americans, what you talked about, the Empowering Patients First Act. This is going to unravel something that has given a lot of Americans peace of mind, knowing that their kids can stay on their health care till they're 26, knowing that they have, if they have a pre-existing condition, that won't stop them from getting care. That's what this hearing should be about. And you're a smart man.
Senator, we're a minute over.
Okay, and my second round, I will be a minute short.
Sure.
Okay, thanks.
You may be here by yourself.
I'll be here with him.
You know, the Benghazi
Senator
hearings
Franken.
was 11 hours. That's all I'm saying.
Thank you, Senator Franken. Senator Isakson.
Congressman Price, since that question ended with him not having any time to give you a chance to respond to it, do you have any response to Senator Franken?
Yeah, I would just say that this is one of the things that makes it difficult to reach a solution here in Washington. The concerns that were expressed by the senator are valid concerns. The conclusions that he drew on the policies that I've promoted and will continue to promote are absolutely incorrect. We all share a concern for the American people and how we best make certain that they have access to the highest quality care that the world knows. And so I hope, and I understand why he's doing it. I mean, this is a political activity. I understand that. But I hope that we're able to work together, if I'm given the privilege of leading and serving as the Secretary of Health and Human Services, to truly solve these difficult challenges that we have in our nation.
Congressman Price, isn't it true that by the date of May 15th of every year since you've served in Congress, you've had to make full disclosure of everything you own, everything your wife owns, what it's worth, when it was acquired, and what it was sold for?
Every single year we do a yearly financial disclosure, and the House requires a monthly periodic transaction form that updates that if there's any significant change.
Isn't it true that every transaction that's been referred to and questions of you were available to the public to find on the records of the Senate Ethics Committee and the House Ethics Committee?
Absolutely, and they remain so today.
These are not discovered things that were hidden. They're, in fact, facts that we require you to disclose every year?
No, in fact, there isn't a single bit of information that's out here that I didn't reveal to the public in a transparent process.
Isn't it true that transparency is the antiseptic that creates the environment where there is no corruption?
Sunshine cures disease. That's exactly right.
Isn't it correct that you've worked throughout your career in the Georgia Senate, United States Congress, and I'm sure you will as Secretary of HHS, to be sure there's always transparency?
Absolutely. It's a hallmark and a key, especially in the area of health care and in the services that HHS provides.
Is it not true that you love your country, you love your job, and if you have the opportunity to be Secretary of Health and Human Services, you'll do everything you can to disclose everything possible so there's never an appearance of any conflict of interest whatsoever?
Without a doubt, and that's why I mentioned the Office of Government Ethics and the work, the diligence that they do to look at everybody's holdings and assets who are scheduled to potentially serve as in the cabinet, and then they make a recommendation, a very specific recommendation that's also available to be seen online. And we have agreed to every single recommendation that they made to divest of whatever holdings we have that might even give the appearance of a possible conflict.
Mr. Chairman, I yield back the balance of my time.
Thank you, Senator Isakson. Senator Bennett.
Thank you, Mr. Chairman, and thank you for the 7 minutes as well. And I should tell you that I have never shown my knee, to any nominee before Dr. Price came to my office, but he gave me some free medical advice, and I'm grateful.
How you doing?
Free health care. It's terrible, but I'll talk to you after it's over. It's not because of you.
I can't ask you, but I'm curious as to whether or not you've gotten the MRI yet.
Today. 3 o'clock,
Good.
so I'll let you know. Congressman, I enjoyed our conversation, and it's good to see you here. I know you've been chair of the House Budget Committee. I know you're a member of the Tea Party, been a strong advocate of balancing the budget, introducing a balanced budget for a stronger America, it's called. What I've noticed is that after gaining control of the House, the Senate, and the White House, the first order of business for the Republican majority here has been to pass a budget resolution repealing the ACA. And this budget resolution specifically authorizes $9 trillion in additional debt over the next 10 years. It also rigs the bill in secret to block any point of order to the bill because that bill will increase the deficit. And let me read my colleague, a smart guy who's here, Senator Paul, so astutely highlighted in his floor speech on January 4th. He said, quote, "The more things change, the more they seem to stay the same. Republicans won the White House. Republicans control the Senate. Republicans control the House. And what will be the first order of business for the new Republican majority? To pass a budget that never balances. To pass a budget that will add $9.7 trillion of new debt over 10 years. This is a facsimile of his chart. Is that really, he asked, what we campaigned on? Is that really what we campaigned on? The quote goes on, why would we vote on a budget that adds $9.7 trillion to the debt? Because we're in a hurry. We can't be bothered. It's just numbers. I was told again and again, swallow it, take it. They're just numbers. Don't worry, it's not really a budget. And yet the legislation says it's a budget. Quote, so this is what Republicans are for. This is the blueprint that the Republican Party says they're for. $10 trillion worth of new debt. I'm not for it, said that honest man. Rand Paul is right. The repeal law overrides 2 separate budget provisions already passed by the Senate that prevent increasing the deficit by more than $10 billion in a given year, increase the deficit more than $5 billion in years further down the road. So I ask you, sir, are you aware that behind closed doors, Republican leadership wrote into this bill that any replacement to the Affordable Care Act would be exempt from Senate rules that prohibit large increases to the deficit?
As you may know, Senator, I stepped aside as chairman of the Budget Committee at the beginning of this year, and so I wasn't involved in the writing of...
You have been the Budget Committee chairman during the rise of the Tea Party. You are a member of the Tea Party caucus. You have said over and over again, as other people have, that the reason you've come to Washington is to reduce our deficit and reduce our debt. I assume you're very well aware of the vehicle that is being used to repeal the Affordable Care Act. This is not some small piece of legislation. This is the Republican budget.
Yes. I'm aware of the bill, yes.
So do you support a budget that increases the debt by $10 trillion?
No, what I support is an opportunity to use reconciliation to address the real challenges in the Affordable Care Act and to make certain that we put in place at the same time a provision that allows us to move the health care system in a much better direction.
Do you support the budget that was passed by the Senate Republicans to repeal the Affordable Care Act that adds $10 trillion of debt to the budget deficit?
Well, the reconciliation bill is yet to come. I support the process that allows for and provides for the fiscal year 17 reconciliation bill to come forward.
Will you commit today that any replacement plan for the Affordable Care Act will not in any way contribute to our deficit or our debt?
I commit to working with you to make certain that that happens.
Will you commit, as a member of the Tea Party, that no replacement for this dreadful Obamacare that allegedly created this deficit and debt will add to the deficit and debt. Will you commit to that? Can't you tell the Tea Party you're not going to increase the deficit by repealing the Affordable Care Act?
There are a lot of contributions to the debt and to the deficit, as you know, Senator.
That's true, and you and I talked about that briefly. Right. Are you going to allow the repeal of the health care bill to be one of those contributors to our deficit and to our debt? The CBO has said that repeal of the health care law could increase our deficit by up to $353 billion. That's what they've said. Senator Paul, an honest man, has gone to the floor and said the first thing we're doing is passing a budget that increases it by $10 billion. What do you say to the Tea Party about that?
What I say to the congressional...
Or more important, people that live in Colorado.
What I say to folks in Colorado and across this land, that the Congressional Budget Office and the conclusions that they reached on that are in a silo. They're looking at it as if nothing else happened following the repeal of the Affordable Care Act. And so if you look at the whole constellation of things that will occur, I believe, in working with every member of Congress, should I be given the privilege of serving as the Secretary, we will make certain that it addresses the health care challenges that exist out there that are very, very real, and we look forward to working with you and committing to work with you on being as fiscally responsible as we can possibly be, because the debt and the deficit is a real challenge.
With respect, and I have a lot for you, with respect, that's what every politician says about the CBO. It says the numbers aren't true, and then we just run up the debt and run up the debt and run up the debt. And almost the entire theory of the case here, I think, from the Republican Party on this subject has been that the health care law has increased costs, that the health care law has increased our deficit, increased our debt, and I would hope that you could take a pledge today that would say that nothing that you would advocate for would pass or have the President sign into law, the President-elect sign into law, would add $1 to our deficit or our debt.
Well, I certainly hope that's the case, and again, look forward to working with you to ensure that it is.
Thank you, Mr. Chairman. I yield back my time.
Thanks, Senator Bennett. Senator Collins.
Thank you, Mr. Chairman. Dr. Price, welcome.
Thank you.
I, too, very much enjoyed our discussion on a wide range of healthcare issues in my office. Many of us have expressed concern about what would happen to the millions of Americans who are in the individual market of the ACA on the exchanges. But there has been remarkably little debate on what would happen if Congress took no action with regard to the individual market. Could you give us your answer as far as what you would see happening to the individual market if we do nothing?
Well, I appreciate that, and I appreciate the opportunity to come visit you. We had a wonderful conversation about many, many different areas. The American people know this. They appreciate that the individual small group market, where many of the millions, as the chairman pointed out, gain their coverage, is breaking in many, many ways. We're in a downward spiral on being able to provide individuals any opportunity at all. So 1/3 of the counties in this nation have just one insurance provider. There are 5 states that have only one insurance provider. There are the premiums are going up for folks, the deductibles. I get calls almost weekly from my former fellow physicians who tell me that their patients are making decisions about not getting the kind of care that they need because they can't afford the deductible. If you're an individual out there making $30,000, $40,000, $50,000 a year, and your deductible is now $6,000 or $12,000 for a family, which is not unusual on the exchange, you may have an insurance card. It may have a wonderful name of an insurance company on there, but you don't have any care because you can't afford the deductible. And so people are denying themselves the kind of care that they need, and those are the things that we ought to be addressing. And again, I hope that in a bipartisan way we'll be able to do that.
Thank you. I think that's a very important point to clarify, that in the individual market we're seeing double-digit increases in premiums, higher deductibles, larger copays, and we're also seeing far fewer choices as more and more insurers give up and flee the market. The co-ops have failed dramatically. All 23 of them are in financial trouble. Only 5 are still operating. So for us to say that everything is going well with Obamacare is just not accurate. And that's why I feel that we do need to fix the flaws of what is a well-intentioned but deeply problematic law. I want to clarify another issue on the ACA. There's been much debate on whether we should repeal the law with no replacement. I think most people reject that idea. As you said, we don't want to pull the rug out from under people who are relying on the insurance that has been provided through the ACA. Another group has advocated repeal with a 2 or 3 year delay. I think that approach also doesn't work because it creates great anxiety for consumers, and insurers would be unable to price their policies if they don't know what the rules are going to be. It's my understanding that your goal is to quickly pass a reform package that would provide access to affordable health insurance for all Americans with more choices that we have now. Is that accurate?
Absolutely. It is vital. We oftentimes don't talk also about the 20 million folks that still don't have coverage out there. There are a lot of people that don't, and if we're responsible policymakers and administrators of policy, it's incumbent upon us to step back and say, why is that? What's going on that's making that happen for those 20 million who don't have coverage in spite of all of these grand things that were done? I would suggest that it's because the structure of what was done actually makes it virtually impossible for many individuals to gain that kind of coverage. We, on the other hand, I believe it's important that we work together to put forward a system that actually allows, again, every single American to have the opportunity to purchase the kind of coverage that they think is best for themselves and for their families.
So your goal is actually to have more people,
yes,
thank you, covered by insurance. I have been baffled over the years by what CMS reimburses for and what it fails to reimburse for. Senator Jean Shaheen and I finally scored a victory of getting CMS to cover continuous glucose monitors for individuals with diabetes that have been covered by the vast majority of private insurers. But when those individuals aged into Medicare, they lost that coverage. Made no sense whatsoever. What I'm finding now is that CMS frequently does not pay for services that helps to keep people well. There is a large practice in my state that has a nurse or a medical assistant call individuals with diabetes once a week and check on their blood sugar levels, their adherence to their diets and exercise regimes. And it's had really positive results. Well, the irony is that if diabetes gets out of control and those individuals end up having to have amputations or go blind, CMS, Medicare will pay for that, but it won't pay for that phone call to check on the individual that's helping to control their diabetes and keep them well. Will you pledge to take a look at those kinds of policies and reevaluate what we do pay for?
Absolutely. It's imperative that we're constantly looking and getting the outcomes that we want, and the processes are either helping or obstructing those outcomes.
And finally, I want to touch on biomedical research, which is a passion of mine. I founded both the Diabetes Caucus in 1997, and I also am the founder of the Alzheimer's Task Force in the Senate, which Senator Warner is the co-chair of. Alzheimer's has become our nation's most expensive disease. It costs society $263 billion a year. $150 billion of that comes from Medicare and Medicaid. It's going to bankrupt those programs. It's devastating to families and the victims of the disease. Diabetes consumes 1 out of 3 Medicare dollars. If we invest in biomedical research, we have the possibility of not only improving lives for Americans and curing or coming up with effective treatments for devastating diseases, but also actually lowering healthcare costs. Do you support the increases for NIH that we have passed in the last year and are on track to pass this year as well?
Yeah, NIH is a treasure for our country, and the kinds of things that we should be doing to find cures for those diseases. One of the core avenues to be able to make that happen is through NIH, and I supported the increase. 2 hours.
Thank you. That goes along with your principle of innovation.
Absolutely.
Thank you.
Thank you,
Mr. Chairman.
We've been at this for about 2 hours. I'm going to suspend the operation for about 5 minutes, and then we'll go to Senator Whitehouse, just so we can take a little break. Committee's recessed for 5 minutes. Committee will come to order. Senator Whitehouse is next, followed by Senator Young. Senator Whitehouse.
Thank you, Chairman. Let me ask first to put into the record a letter from our governor in Rhode Island, which says that in Rhode Island, I'm quoting it here, we have actually seen exchange premiums decrease in 2 out of the last 3 years, and that this has saved consumers nearly $220 million since 2012. So the story on the Affordable Care Act in Rhode Island is actually quite a good one.
We put it in the record.
I'd also like to put this little graphic into the record, which, to explain it briefly, the red line along the top is the CBO estimate of where our health care costs were going to go back when they were making that estimate in 2010. And then at this time, 2016, after the ACA was in place, they took a look at the actual experience up to that point, and then they did a new projection going forward based on the Affordable Care Act. And just in the following 10 years, this green period from 2016 to 2026, they're forecasting $2.9 trillion in federal health care savings that relate back to the Affordable Care Act. This is where that came in. So we throw this thing out at our peril. If you care about saving Medicare, the savings to which are a very significant part of this $2.9 trillion, and we throw it out right now, according to the Republican plan, with nothing to replace it. I've described that over the weekend at home as like being asked to jump out of an airplane with no parachute, but being told, trust you, we'll build the parachute before you hit the ground. I'm the junior senator to Jack Reed, who was an Army Ranger and actually did jump out of perfectly well operating aircraft. He insisted not on just one parachute, but 2, a spare. And I think the American people are entitled to know what they're going to be offered as an alternative. There's been some conversation in this hearing about how there are Republican ideas floating around, and sure there are Republican ideas floating around, but there's no Republican bill, there's no Republican plan, there's no Republican proposal. Our cards are up on the table. It's Obamacare. You want to improve it? Make suggestions. We've always been open to that. But on the other side of the table, there's nothing. And it's really hard to negotiate with nothing. And I think the Republicans have a responsibility to put a plan together. Now, we talked about that, Mr. Price, when you and I met in my office. And my recollection of our conversation is that you told me that you would want to keep letting people stay on their parents' policies until they're 26. Is that true?
I think that the insurance industry has included individuals up to the age of 26 on their parents' policies virtually across the board, and I don't see any reason that that would change.
And you would want to keep, you told me, the donut hole closed to protect seniors against those pharmaceutical costs. Is that also true?
I think the discussion we had was about pharmaceutical costs and making certain that we did all we could so that seniors were able to afford the kind of drugs that they need.
My recollection was more specific than that, that you did not want to reopen the donut hole for seniors. Are you saying now that you're going to consider reopening the donut hole for seniors?
No, that's not what I'm saying at all. I think that it's important. You know well that the reopening of the donut hole would be a legislative activity, not an administrative activity.
Secretary of Health and Human Services, you will be doing a lot of work to prepare this legislation and to do the technical work behind it for the administration. Are you going to be proposing in that role something that reopens the donut hole? I've got a lot of seniors who want to hear about that if that's your plan.
I'm not aware of any discussions to do that.
Okay. And then finally, my recollection of that meeting and my notes are that you told me that you would not want to return to insurance company lifetime caps or insurance company denial of pre-existing conditions, or insurance companies going back and looking in the files for some little tiny discrepancy and then throwing somebody off their coverage when they come in with a significant claim. Is that true?
I think there are always ways that we can improve coverage, and those are areas that are existent right now, and I think they need to be the issues need to be continued.
So when, as, and if we ever get a Republican counterproposal to Obamacare, you would expect to see those things in it?
I don't know whether they'd be in it or whether they would be silent on it. But again, that's a legislative question.
They'd leave it in place.
It's a legislative question, not an administrative question.
Now, in one of your budgets, you had a proposal that would allow states to throw what you called able-bodied people off of Medicaid unless they were working or looking for work or in job training. People with addiction, behavioral health, mental health issues, are they able-bodied in your definition?
Well, we weren't as specific as what the definition was. The fact of the matter is,
words. I'm asking you now. What did you mean when you said able-bodied in this provision?
The fact is that there are many, many individuals who have worked in this space for a long, long time who believe that providing for an opportunity for individuals who are able-bodied without children to seek or gain employment or to study.
And what do you mean by able-bodied is the question. You just used that term again.
And that's what would be defined in the regulation itself. So I don't
know. You used the term without an idea of how you would define it?
I think people have an understanding of what able-bodied is, and that's somebody who doesn't have the kinds of things that you described, I believe.
So that was the simple answer to my question. Able-bodied does not include people who have addiction, mental health, and behavioral health issues.
Again, it's the work that would be done to develop the regulation.
I meant as you used the word. I'm not asking about in some future universe. As you use that term in your budget.
I think individuals that demonstrated that they were in fact having challenges that would preclude them from being able to seek work or employment or education or the like, that they ought to be attended to.
Now, I'm a fan of and think they do good work of the American Academy of Pediatrics. I'm a fan of and think they do good work of the American Lung Association. And I'm a fan of and think they do good work of the American Public Health Association. All of those groups and many others have gone very clearly on record that climate change presents significant health issues. They signed a declaration on climate change and health, which stated that the science is clear that this is happening. You, on the other hand, have said that the carbon pollution standards of the Obama administration, quote, go against all common sense, and that there are errors and obfuscation in the allegedly settled science of global warming. I'll pursue this with you through questions for the record because my time has expired, but if you could give a brief answer, because it appears to every scientific organization in the country, all the legitimate major ones, and to really every American university, that this actually is pretty darn settled science, and that the only people who disagree with it are people who have vast financial interests in preventing any work getting done. And it looks to me like in making this statement, you have taken the side of those vast special interests against actually settled science. And if we can't trust you on science that is as settled as climate science, how can we trust you on public health science issues where there's a big special interest on the other side?
I don't agree with the premise or the insinuation, but I will say that the climate is obviously changing. It's continuously changing. The question from a scientific standpoint is what effect does human behavior and human activity have on that, and what we can do to mitigate that. And I believe that's a question that needs to be studied and evaluated and get the best minds available to make
Start
certain that
by
we're doing
finding
the
me
right
a university
thing from a
that
public
thinks the
policy
way you
standpoint.
do. One.
Okay, we're running out of time. Thank you, Senator Whitehouse. Senator Young, I believe, is next. I don't see him. Senator Roberts.
Well, thank you, Mr. Chairman. Thank you for holding this anger management hearing. I truly hope my colleagues feel better, at least for one day, after purging themselves of their concern, their frustration, and their anger. I would like to note that I asked the technician here that is running the sound system. The audio system is working. I thought maybe Senator Bennett didn't know that. And he reminded me of my Marine DI back in the good days, where the DI would shout, "I can't hear you!" So I just thought I'd bring that up. The audio system's working. Take care of yourselves. Dr. Price, congratulations on your nomination. Thank you for being here today.
Thank you.
As many of our colleagues have already noted, you will play a most important role, if confirmed, in helping to stabilize the individual market while Congress does repeal the law and repair the damage it has caused and enacts the reforms I believe, will put our health care system back on track. Now, in my home state of Kansas, we have 3 insurance carriers left. We feel very fortunate we have 3. With each individual only having access to 2 of those, and our premiums rose this past year over 30%. Down the road, it's going to be more difficult if we don't do something. There's no doubt with regard to uncertainty and angst among consumers. I think it's important to make clear that even if Congress and the incoming administration were to do nothing, let it go, just like in Frozen, let it go. And amending or repealing parts of the Affordable Health Care Act, the law is not working. And we have to do something to meet that obligation. The prices are unaffordable, markets nearly non-existent, with few or no options in several states and counties. We're not as rural as Wyoming, but we are rural in my state of Kansas. I have a concern back in the day when we sat in this committee and wrote the first version of the Affordable Health Care Act. I don't know where that mark is today. It's sitting on a shelf somewhere. But we went day and night and day and night and day and night, and I was worried about something I called the rationers. I'm talking about the Independent Payment Advisory Board, IPAB, the Centers for Medicare and Medicaid Innovation, CIMI, that's a wonderful acronym, and the new coverage authorities given to the U.S. Preventive Services Task Force, and I would also mention the Patient Center Outcomes Research Institute, which is called PCORI. Not many people are aware of these. I even went to the floor of the Senate and had 4 people riding a horse and called them the 4 horses of regulatory apocalypse. But I'm worried about it, and the provisions which could interrupt the doctor-patient relationship, allowing the government to dictate what coverage you can receive. Can you share some of any concerns that you have with regards to these, what I would call four rationers, with all due respect of what they're trying to do with good intent?
Yeah, I appreciate that, Senator. I think that it's imperative that as we move forward, that we recognize again that the patient ought to be at the center of this, and anything that gets in the way of the patient and their families and physicians making the decisions about what kind of health care they desire we ought not go down that road. And so, for example, the CMMI, the Center for Medicare and Medicaid Innovation, I'm a strong, as I've mentioned, strong proponent and advocate for innovation. But I've seen in certain instances what's coming out of CMMI is a desire to require certain kinds of treatment for certain disease entities that may or may not be in the best interest of the patient. And because it carries the full force of the federal government and the payment for those services, it means that we're answering the question, who decides about what kind of care patients receive, by saying that the answer to that ought to be Washington, D.C., and I simply reject that that's where those decisions ought to be made.
I appreciate that answer. I have the privilege of being a member of this committee, the Finance Committee, and especially being chairman of the always powerful Senate Agriculture Committee. I'm particularly interested in HHS and, more importantly, FDA's work on food and nutrition policy. During the previous administration, the FDA issued numerous regulations with limited or delayed guidance and unrealistic compliance dates. This was the case with the implementation of the Food Safety Modernization Act, called FSMA, and more recently with the Nutrition Facts Panel revision. I know we all share the goal of a safe food supply and availability of accurate information for consumers, but I'm concerned the administration has not clearly or consistently communicated with the food and agriculture industry regarding new or changing requirements. Will you commit to working with the Secretary of Agriculture and other relevant agencies, not to mention the committee I serve on and similar in the House, that your department is issuing science-based guidance and taking into consideration other regulatory burdens when establishing compliance and dates, engaging in other regulatory actions?
Yes, I believe that's not only imperative, but the science that's relied upon ought to be transparent and available to the public so that people can see exactly what was the basis for the decisions that were being made.
Under the previous administration, we have seen increased activity and regulatory action on nutrition policies, such as issuing voluntary guidance. Yet the same administration continued to request additional resources from Congress to comply with statutory requirements under the Food Safety Modernization Act. I'm concerned that the administration did not prioritize FDA's mission to protect our nation's food supply, instead focusing on nutrition policies. If confirmed, can you discuss how you will focus on the core FDA duties, such as implementing the law that Congress passed, rather than agenda-driven nutrition policy guidelines?
Yeah, this is really important, Senator. And if I'm confirmed and given the privilege of leading, I would work specifically with the FDA Commissioner and make certain that we are relying on science, that it's science that is guiding the decisions that we're making, and again, that the transparency is available for folks so that they can see what kind of decisions are made and how they're being made. In addition to working with policymakers, you know best what's going on in your state and how it's being affected by the rules and regulations that are coming down from Washington in so many areas, but certainly in the agricultural arena. And so we ought to be having a dialogue with every single individual who has an interest to make certain that we're addressing the needs appropriately.
I thank you for your response. Thank you, Mr. Chairman.
Thank you, Senator Roberts. Senator Baldwin.
Thank you, Mr. Chairman. Welcome,
Thank you,
Congressman. You've already been asked about your investments in medical device companies, pharmaceutical companies, as part of the prior questioning. But for the record, have you also received campaign contributions over the years from political action committees associated with many of these same companies?
I don't know, but I assume so, just as many of us do.
Okay. So in terms of, I mean, what the American people want to know, of course, when you get reviewed for potential conflicts of interest and, you know, your procedures with the Office of Government Ethics, is that, that in your role, you're fighting for them and not biased towards the powerful companies that you've invested in and that have invested in you. And you've taken some questions on that, but just let me follow up a little bit to ask first, do you think drug price increases that we're seeing right now, for example, the six-fold increase in the cost of an EpiPen, is a problem right now for Americans?
Oh, as I mentioned, I think there are certain areas where drug pricing increases seem to have little basis in rational findings. I do think, however, as I mentioned again, I think I did, that it's important to appreciate that we've done some good things in the area of drug pricing, whether it's in the generic arena where the prices have been held down significantly, and the Part D area where prices are...
Since my time is limited, let me continue down this, this track. You've been asked already, but Trump supports Medicare drug negotiation. Will you work to repeal the prohibition on Medicare negotiating for better drug prices on behalf of the American people if confirmed for this position?
Well, I understand that if I'm confirmed and if I have the privilege of serving as Secretary, that the boss that I have will be the President of the United States.
So will you work to repeal the prohibition on Medicare negotiating drug prices?
Following discussion and being informed by the individuals within the department and working with the President and then carrying out his wishes.
Was that a yes or was that a no?
It depends on that activity. I would hope
he
that...
He stated his position very recently, in fact, that he supports price negotiation so that people on Medicare can have the benefit of that. Is that something that you would press Congress to do? In other words, repeal the prohibition on that negotiation?
I think we need to find solutions to the challenges of folks gaining access to needed medication. And it may be that one of those is changing the way that the negotiations occur. As you know, the negotiations right now occur for seniors with the PBMs, with the pharmacy benefit managers.
And you haven't said yes or no. You just talked about transparency. Would you support drug price transparency, mandating that any drug company that wants to increase prices on their drugs release public information on how they set their prices, because so many of these appear to be without justification, as you just mentioned?
Yeah, I think there's a lot of merit in transparency in every area, and certainly in this area. And I'd look forward to exploring, if I'm confirmed with you, the ways to be able to make that work.
Thank you. So I wanted to go back to the first round of questioning with the chairman who showed a chart, and it seemed like what was implicit in the back and forth was that the act of repealing the Affordable Care Act would only impact perhaps a very small part of the health care industry. You talked about 6% being covered on the individual market. The protections, like coverage on your parents' health insurance till you're 26 and mandating that people be covered even if they have a pre-existing health condition. Things like eliminating caps that led so many into medical bankruptcy, those apply across the healthcare system. So repeal in no way limits us to a conversation just about a small percentage of our population. This is about serious impacts for all of America. Would you agree?
I think that the discussion about what our health policy for financing and delivery of health care to the American people is a very, very broad subject, and we need to discuss...
if you repeal the Affordable Care Act, the impact is not narrowly confined to Medicaid and the individual market. It has impact on every American. And Medicare, too. Think of accountable care organizations where we're driving so much of our innovation. That's not confined to the individual market. In fact, it impacts Medicare very, very significantly. So let me give one example. We in our office, when you visited, and thank you for your visit, we talked about the opioid epidemic. One of the significant issues is access to treatment to overcome an addiction. If the Affordable Care Act is repealed, there will no longer be a mandate for substance abuse treatment being covered. Is that something you agree with?
Look, the opioid epidemic is rampant and is harming families and communities all across this nation.
Would you assure that treatment would be substance abuse treatment would be covered under a replacement plan that you would propose?
I think it's absolutely vital that substance abuse and other kinds of things are able to be treated. So you would keep that protection of the Affordable Care Act? That's a legislative decision, but I look forward to working with you to make certain that we're ensuring that individuals are able to get the care they need.
I want to make sure I heard the exchange, because it sounded to me like you're saying you think insurers are just going to continue to do it, so that there's no need for there to be an actual mandate saying they must. And mind you, with 5.7 million young people between the ages of 18 and 26 on their parents' health insurance, that's 5.7 million people who aren't in the individual market because they're in their first job after high school that doesn't have health insurance, or in school without... Is it just a wink and a promise, or do you support having in law a mandate that 18 to 25-year-olds be able to stay on their parents' health insurance?
What I have, as I say, I think it's been baked into the insurance programs that are out there right now. What I absolutely am committed to.
But they could change their mind at any time.
What I'm absolutely committed to is making certain that every single American has access to the kind of coverage that they want and has the financial feasibility to be able to purchase that coverage.
Thank you, Senator Baldwin. Senator Young.
Dr. Price, so good to see you here today.
Thank you.
I've enjoyed our service together over the last 6 years in the House of Representatives, particularly the 4 years we spent on the Ways and Means Committee. And I had an opportunity not just to get to know you personally there, but to observe your quite impressive skill set, your depth of knowledge in the area of health care and health policy, your commitment, more importantly, to seeking alternative perspectives, to trying to identify where bipartisan consensus could be realized, and ultimately forging consensus around some viable solutions. The one that I find most notable is your success on the sustainable growth rate, which is something the members of this committee are familiar with, but it's a blunt instrument that was in place to control health care costs. And without your leadership over on the House side, I don't think we could have moved towards a more value-based purchasing model. So these are skill sets that will serve you well over at Health and Human Services, no doubt. One area of the Affordable Care Act, speaking of bipartisanship, that members of my party, of your party, have periodically and quite vocally indicated their desire to repeal from time to time, has been the Center for Medicare and Medicaid Innovation. And that's perhaps on account of the one-size-fits-all prescriptive and mandatory demonstrations that occurred in recent years. And you've already indicated that you oppose the mandatory nature of demonstration projects. But I strongly believe, for one, that there's great value in innovating and experimenting across all layers of healthcare. Further, I think CMMI is and can continue to be a helpful laboratory for healthcare experimentation with respect to delivery models, payment models, and so forth, for Medicare, for Medicaid, for the Children's Health Insurance Program, perhaps other areas. Save taxpayer money, provide greater value. We see what doesn't work. We scale up what does work. For me, it's common sense. This is the way sort of scientists operate, is they start with experiments, and then they evaluate, and then they scale up. So I'd like to know your intentions. if you have strong convictions in this area. Do you intend to keep this innovation center or perhaps develop a new one, a variant of CMMI? Speak to this, please.
Well, I appreciate that, and I'm, as I mentioned, a strong advocate and supporter of innovation at every single level. It's only through innovation that we expand the possibilities for especially in the area of healthcare, for increasing the quality of care. So I'm a strong proponent of innovation. The CMMI entity, I believe, has great possibility and great promise to be able to do things that will allow us to find ways in which we can change the payment model, ways in which we're treating disease and the like that will improve to the patient's benefit. And I strongly support that. I have adamantly opposed the mandatory nature with which CMMI has approached some specific problems. And let me mention two in particular, if I may. The first is the Comprehensive Joint Replacement, the CJR program, which identified from CMMI 67 or 68 geographic areas where if you were a patient and you received a lower extremity joint replacement for a variety of problems, then it was dictated to your doctor what kind of prosthesis, what kind of surgical procedure your doctor could do for you, regardless of what's in your best interest. Now, they may be aligned, but they may not be aligned. And if they're not aligned, then your physician is incumbent upon doing what the government says to do. The other area that I think was even more egregious was covering 75% of the nation in the Medicare Part B drug demonstration model. In fact, not a demonstration model if it's 75% of the country. And that would stipulate what kind of medications your physician could use in an inpatient setting. In a mandatory way. Now, the problem that I've got with that is that really is an experiment. It's a demonstration to see whether or not it works. And in every single experiment, healthcare experiment or medical experiment or scientific experiment that deals with people, real people, we require that there be informed consent for the patient to participate in that experiment. And so you say to the patient, we're trying this to see if it works better. We'd love to have you join us. We think it may inure to your benefit and the benefit of more individuals across this land. But if you don't want to do that, you don't have to. The federal government doesn't do that. They require individuals to participate. And oftentimes, I suspect most often, the patient doesn't even know that it's an experiment that's going on. So if either of these models were put in a small area, a pilot project somewhere, and we saw that in fact they worked, then as you say, then you scale them up.
I thank you for the fulsome response and the rationale behind how you've arrived at that position. I look forward to working with you to advance the next model of CMMI, whatever exactly it might look like. I'd be remiss in my remaining 90 seconds if I didn't mention Indiana's what we call Healthy Indiana Plan 2.0. Our Vice President-elect, Pence, showed a lot of leadership here, worked with our incoming CMS Administrator, Seema Verma, to develop a model for Medicaid, which is unique to the state of Indiana. It encourages recipients of Medicare dollars to get some ownership over their health. It uses private market insurance concepts to prepare Hoosiers for more self-sufficiency. I happen to believe that it will be replicated in other states if we can accommodate that as we continue to work on new health care legislation. But HIP 2.0 is an important proof of concept that Medicaid can be more efficient than a one-size-fits-all approach. And I just need some assurance from you that your lodestar will be state flexibility and innovation in the Medicaid space so we can continue to accommodate plans like HIP 2.0 as opposed to a one-size-fits-all approach.
I think you're absolutely right. The Medicaid program is one where the states know best how to care for in the best way their Medicaid population. And the greatest amount of flexibility that we can give, I think, for states to enact those kinds of programs. What Indiana has done is really a best practice, I think, for many other states to follow. And so I look forward to working with you.
Likewise.
Thank you, Senator Young. Senator Murphy.
Thank you, Mr. Chairman. Good to see you again, Representative Price.
Senator.
I hope you can understand our frustration around trying to divine the nature of this replacement plan. we hear you and President Trump praise all of these aspects of the Affordable Care Act and lay out goals that sound eerily familiar to what we've been living with for the last 6 years. You've said that you don't want there to be a gap between the repeal and the replacement, that at least as many people will have coverage, with the goal of more people having coverage. Sick people won't face discrimination. Young adults will get to stay on their plans until age 26. And yet, we don't get any specifics as to how that's going to occur. It seems as if you and the President-elect want to do everything the Affordable Care Act does, but just do it in a totally different way. And so I'm going to kind of give up on trying to get at the specifics of this secret replacement plan and maybe ask you about metrics, about how we will measure whether what you propose as a replacement is meeting your benchmarks. For instance, the number of people covered, the cost of health care to individuals, the amount of money out of pocket that people have to pay. When you're at the end of your 4 years, how will you look back on this replacement plan to measure its success? And to the extent you can give me specifics as to how you're going to measure the success of this replacement, I appreciate it.
Well, I thank you, and you identified some very specific areas that I think we need to be looking from a metric standpoint. What is the cost? Is the out-of-pocket cost for individuals higher or lower than it was? Right now, I would suggest that the cost is higher than it was when the program began for many of those individuals in the individual and small group market. They were promised that the premiums would come down. In fact, the premiums have gone up. They were promised that they'd have access to their doctor. In fact, many of them have not had access.
But I'm talking about from where we are today.
So from where we are today, if you look at the things that many of us believe have been harmed by the Affordable Care Act, I hope that we're able to turn that around and decrease the out-of-pocket costs for individuals, increase choices for individuals, increased access to the doctors and the providers that the patients want, as opposed to what's happened over the past few years.
Increase the number of people who have insurance.
Absolutely. We've still, as I mentioned over here, we still have 20 million individuals without coverage. I think as policymakers, it's incumbent upon us to say, what can we do to increase that coverage? That the goal is to make certain that every single American has that access to coverage that they want for themselves and for their family.
I'll just know that those are two different things, having coverage and having access to coverage, and I think we've gone around on that a number of times. So I want to come back to this question of some of the conflict of interest issues that have been raised, and I raise it because I think there's a great concern on behalf of the American people that this whole administration is starting to look like a bit of a get-rich-quick scheme, that we have a president who won't divest himself from his businesses and could potentially get rich off of them. We had a Secretary of Education last night who has big investments in the education space, a Secretary of Labor who could gut worker protections and make a lot of money for his industry. And so I want to walk you through another set of facts, another timeline regarding some of your interactions with the healthcare industry and get your reaction to it. On March 8th of 2016, earlier last year, CMS announced a demonstration project to lower Medicare reimbursements for Part D drugs. That would have decreased incentives for physicians to prescribe expensive brand name medications, and drug companies that were affected by this immediately organized a resistance campaign. 2 days later, you announced your opposition to this demonstration project. 1 week later, you invested as much as $90,000 in a total of 6 pharmaceutical companies, not 5, not 7, 6. All 6, amazingly, made drugs that would have been impacted by this demonstration project. There are a lot of companies, drug companies, that wouldn't have been affected, but you didn't invest in any of those. You invested in 6 specific companies that would be harmed by the demonstration project. You submitted financial disclosures indicating that you knew that you owned these stocks. And then 2 weeks after that, you became the leader in the United States Congress in opposition to this demonstration project. You led a letter with 242 members of Congress opposing that demo. I've led those letters. I know that's not easy. That takes a lot of work to get 242 people to sign on.
That's good staff work, Senator.
And then guess what? Within 2 weeks of you taking the lead on opposition to that demonstration project, the stock prices for 4 of those 6 companies went up. You didn't have to buy those stocks, knowing that you were going to take a leadership role in the effort to inflate their value. And so as the American public take a look at that sequence of events, tell me how it can possibly be okay that you are championing positions on healthcare issues that have the effect of increasing your own personal wealth. That's a damning timeline, Representative Price.
Well, my opposition to having the federal government dictate what drugs are available to patients is long-standing, goes back years and years. The fact of the matter is, and I don't know whether you were here before, but the fact of the matter is that I didn't know any of those trades were being made. I have a directed account, broker-directed account. All of those trades were made without my knowledge, as is set up, and individuals on this panel have the same kind of accounts. The reason that you know about them is because I appropriately reported them in an above-board and ethical and appropriate manner as required by the House of Representatives.
But do you direct your broker around ethical guidelines? Do you tell him, for instance, not to invest in companies that are directly connected to your advocacy? Because it seems like a great deal as a broker. He can just sit back, take a look at the positions that you're taking.
She can sit back.
She can sit back, in this case, look at the legislative positions you're taking, and invest in companies that she thinks are going to increase in value based on your legislative activities, and you can claim separation from that because you didn't have a conversation.
Well, that's a nefarious arrangement that I'm really astounded by. The fact of the matter is that I have had no conversations with my broker about any political activity at all, other than her congratulating me on my election.
But why wouldn't you at least tell her, hey, listen, stay clear of any companies that are directly affected by my legislative work?
Because the agreement that we have is that she provide a diversified portfolio, which is exactly what virtually every one of you have in your investment opportunities, and make certain that in order to protect one's assets, that there's a diversified arrangement for purchase of stocks. I knew nothing about those purchases.
But you couldn't have a diversified portfolio while staying clear of the 6 companies that were directly affected by your work on that issue?
As I said, I didn't have any knowledge of those purchases.
Okay. Thank you, Mr. Chairman.
Thanks, Senator Murphy. Senator Murkowski.
Thank you, Mr. Chairman. There is added benefit to being one of the last in the chain here to ask questions, because it certainly gives me a clear idea of where you're coming from, Congressman, on some of these issues that are so important to us. We haven't had as much conversation about the rural aspects of health care, which of course are very important to me. We had a chance last night to hear from the nominee for education, and I pointed out to her, as I have pointed out to you, that Alaska is a little bit unique. Sometimes it's really unique, and the challenges that we face allow us to be somewhat innovative, but we need some flexibility in order to implement some of the innovations. I had a chance to sit with a group of Alaskans on Saturday in Anchorage. They were from everyone from the Director of the Division of Insurance to our Commissioner of Health and Social Services, our representative of the only provider on the individual market, representatives from small rural hospitals, doctors. It was representatives from the tribal health organizations. So it was a good mix of individuals. Obviously, we got different views and opinions about where we go with this replacement of the ACA and what that would need to look like to help address the needs and issues in a very rural, very frontier, very high cost, the highest cost insurance, the highest cost healthcare costs. We're down to one provider on the individual market. So we've got all the demographics that would tell you that this is a difficult place to be operating right now. We, as a state, moved forward with Medicaid expansion a couple years ago. There's some 27,000 Alaskans that now have coverage that didn't see that before. There was also good discussion about making sure that we're able to retain the protections for Alaska Natives that we saw under the Indian Health Care Reorganization Act that came as part of the ACA. So recognizing that there are certain exemptions that were included as part of the ACA. Exemptions from Medicaid cost-sharing provisions, 100% federal match for American Indians and Alaska Native Medicaid enrollees when they receive their care through an IHS facility, including the tribally operating facilities. Again, we have seen some, I think, very extraordinary collaboration that has gone on between our entities with our tribes, our tribal health organizations that have allowed for increased efficiency, improved health access. And so a great deal of the discussion was focused on what will happen to those who have gained access through Medicaid expansion, and what can we do to ensure that coverage options are provided for those in this new era of health care reform. And then a further question to that is, should a block grant approach be considered? What efforts then would be made to ensure that this very unique trust responsibility for American Indians and Alaska Natives are continued to be fulfilled? These were concerns that were raised in this meeting, and folks had hoped that I'd have an opportunity to ask you publicly.
Yeah, thanks so much, Senator. I appreciate it. And we had a wonderful discussion about Alaska, and I learned much about your state, your glorious state. The Medicaid system is one that is absolutely imperative and vital for members of our population who receive their care through the Medicaid program, and it's a federal-state partnership, as you well know, and it's one that we absolutely must ensure that individuals don't fall through the cracks in whatever transition occurs. So whether it's retaining the same level of Medicaid participation or whether it's providing an option for something else that allows them the coverage that suits their needs, we are committed and adamant that coverage be able to be continued. So they have our assurance that we will work with you to make certain that happens.
What about the concerns that were expressed by the tribal health organizations that perhaps if there is a block grant approach that is utilized, that could impact some of the assurances and the benefits that the tribal health organizations have seen?
Yeah, and this is in its early stage, obviously, and it's a legislative decision that occurs. It's not a department decision that occurs, a legislative decision. But we would look forward to working with you to, and again, ensure that individuals, especially in the Indian Health Service, which have had some real challenges, and we need to make certain that the metrics, as was mentioned over here, the metrics that we're looking at are actually clinical correlative metrics, that we're looking at what actually makes a difference to the people receiving the care, it's one of those promises that we have to make certain that the Indian Health Service works, and I think we can do a lot better at that.
Well, I look forward to more conversation on that. Let me ask about some of the efforts that Alaska has made, I think relatively innovative, as we have attempted to stabilize our individual health care market. The state moved forward with some reforms. They created a reinsurance program for high-cost, high-risk individuals. We've submitted a 1332 state innovation waiver. And again, all with the hope that we're going to be able to somehow provide for some level of stabilization. What sort of considerations to federal support for high-risk pools or state-based reinsurance programs would you consider?
I think the whole array of opportunities that are available to, again, make certain that nobody falls through the cracks. The 1332 waiver program is one that's just beginning, but it's one that I think holds significant promise in making certain that we're able to ensure that things like reinsurance, things like high-risk pools, make it so that individuals do not lose their opportunity to gain access to the highest quality care.
Good. And then finally, on our small rural hospitals, one of the concerns that I heard repeatedly was the level of regulatory burden that particularly our smaller rural hospitals are just feeling stifled by. In fact, some of the innovative things that one of our hospitals down on the Kenai Peninsula is looking at advancing, they kind of feel that it's too risky right now to move forward with any level of innovation that they had hoped to take on because they're facing some of the regulatory burden, but also the uncertainty that they are in right now. You can do things administratively early on should you be confirmed to this position. Have you looked to what regulatory issues could be addressed early on that could help reduce some of the regulatory burden, particularly to some of these small rural hospitals?
Not specifically, Senator, but I share with you the concern that you have about the burden of regulatory guidelines and regulatory schemes that come out of Washington, D.C., especially for the rural area. And it's not just the hospital, it's the providers and the docs who are providing the care. Most of the folks in the rural area tend not to have any margin at all to be able to cover the cost of this regulation. And I've heard from more than a few physicians and other providers who, because of the regulatory schemes that have come forward, have said they just can't do it anymore. They're having to close their doors. And Indian Health Service is one of them where they're having real challenges in terms of being able to provide the services. And so when that happens, then those individuals have no care. And that's unacceptable to me.
Thank you. I look forward to working with you on this.
Thank you.
Thank you, Senator Murkowski. I have remaining Senator Warren, Hassan, and Kane on the Democratic side. Senator Scott, Cassidy, Burr, and Senator Isakson has 3 minutes remaining. Senator Warren.
Thank you, Mr. Chairman. Congressman Price, more than 100 million Americans now receive their health care through Medicare and Medicaid programs. These are seniors, people with disabilities, middle-class families who have parents in nursing homes, countless numbers of young children, and they all benefit from these programs. So I want to understand the changes to Medicare and Medicaid that you have already proposed. The budget that you recently authored as chair of the House Budget Committee would have cut spending on Medicare by $449 billion over the next decade. Is that right?
I don't have the numbers right in front of me, but what we're trying.
The numbers.
Well, then I assume you're correct.
All right. So you said you'd cut it by cut Medicare by $449 billion. Your FY17 budget proposal also would have cut Medicaid funding that goes to the state governments by more than $1 trillion. Is that correct?
I think, Senator, the metrics that we use for the success of these programs is not necessarily whether the amount of money into it is what we ought to be looking at.
For Medicaid.
What we believe is appropriate is
Do you want me to read you the number out of this?
No, I'm sure you're correct. What we believe is appropriate is to make certain that the individuals receiving the care are actually receiving care.
I understand why you think you're right to cut it. I'm just asking the question, did you propose to cut more than $1 trillion out of Medicaid over the next 10 years?
You have the numbers before you.
Is that a yes?
You have the numbers before you.
I'll take it as a yes. So, as I'm sure you're aware, during his campaign for president, President-elect Trump was very clear about his views on Medicare and Medicaid. As Senator Sanders has quoted extensively, President-elect Trump said, I am not going to cut Medicare or Medicaid. Now, when President-elect Trump said, I am not going to cut Medicare or Medicaid, do you believe he was telling the truth?
I believe so, yes.
Yeah, okay. Given your record of proposing massive cuts to these programs, along with several other members of this committee, I sent the President-elect a letter in December asking him to clarify his position. And he hasn't responded yet, so I was hoping you could clear this up. Can you guarantee to this committee that you will safeguard President-elect Trump's promise, and while you are HHS Secretary, you will not use your administrative authority to carry out a single dollar of cuts to Medicare or Medicaid eligibility or benefits?
What the question presumes is that money is the metric. In my belief,
yes,
from a scientific standpoint, if patients aren't receiving care, even though we're providing the resources, then it doesn't work for patients.
I'm sorry to interrupt, but we're very limited on time. The metric is money. And the quote from the President-elect of the United States was not a long discourse on this. He said he would not cut dollars from this program. So that's the question I'm asking you. Can you assure this committee that you will not cut $1 from either Medicare or Medicaid should you be confirmed to this position?
Senator, I believe that the metric ought to be the care that the patients are receiving.
I take that as a no?
It's that's the wrong metric.
Well,
we ought to be putting forth the resources.
I'm not asking you whether or not you think you have a better metric. I'm asking you a question about dollars. Yes or no?
What we ought to do is put forward the resources in order to take care of the
really
patients.
Simple questions. And frankly, the millions of Americans who rely on Medicare and Medicaid today are not going to be very reassured by your notion that you have some metric other than the dollars that they need to provide these services. You know, you might want to print out President-elect Trump's statement, "I am not going to cut Medicare or Medicaid," and post that above your desk in your new office, because Americans will be watching to see if you follow through on that promise. Now, I also would like to follow up on Senator Franken's question. I think there was something there that didn't quite get answered. As you know, Congressman, the one goal of the Affordable Care Act was to push the healthcare industry to provide higher quality care at lower cost. And under the ACA, Medicare was recently allowed to change the way that it pays hospitals for hip and knee replacements to something called a bundle. And that means Medicare pays a set price for the care associated with hip and knee replacement, and then the hospitals, not Congress, will decide the most effective implants, reduce second surgeries, better fight infections, how to spend their money to deliver better service at higher cost. Now, I've supported this change because the research shows that it really means you get better care at lower prices. But I know the policy is controversial because it affects how hospitals are paid, which in turn affects how much money the manufacturers of these hip and knee replacements can make. And one of the companies is the company raised by Mr. Franken, Senator Franken, and that is Zimmer Biomet. They're one of the world's leading manufacturers of hip and knees, and they make more money if they can charge higher prices and sell more of their products. The company knows this, and so do the stock analysts. So on March 17, 2016, you purchased stock in Zimmer Biomet. Exactly 6 days after you bought the stock, on March 23, 2016, you introduced a bill in the House called the HIP Act that would require HHS Secretary to suspend regulations affecting the payment for hip and knee replacements. Is that correct?
I think the BPCI program to which I think you referred, I'm a strong supporter of because it keeps the decision making.
I'm not asking you about why you support it. I'm just asking, did you buy the stock and then did you introduce a bill that would be helpful to the companies you just bought stock in?
The stock was bought by a broker who was making those decisions. I wasn't making those decisions.
Okay, so you said you weren't making those decisions. Let me just make sure that I understand. These are your stock trades, though. They are listed under your name, right?
They're made on my behalf, yes.
Okay. Was the stock purchased through an index fund?
I don't believe so.
Through a passively managed mutual fund?
No, it's a
through an actively
broker.
Managed mutual fund?
It's a broker-directed
account. Through a blind
account.
trust? So let's just be clear. This is not just a stockbroker, someone you pay to handle the paperwork. This is someone who buys stock at your direction. This is someone who buys and sells the stock you want them to buy and sell.
Not true.
So when you found out
That's not true, Senator.
Well, because you decide not to tell them, wink, wink, nod, nod, and we're all just supposed to believe that?
It's what members of this committee, it's the manner in which members of this committee, well, I understand that, but it's important to appreciate that that's the case.
Then I want to understand, when you found out that your broker had made this trade without your knowledge, did you reprimand her?
What I did was comply.
You found out that she made it.
What I did was comply.
Did you fire her? Did you sell the stock?
What I did was comply with the rules of the House in an ethical and legal and above-board manner and in a transparent way.
You know, all right. Let's just stipulate.
Time has expired, Senator Warren.
I believe Senator Murkowski went over by 2 minutes. Did I read the clock here?
By 2 minutes.
I think that's what it was, and I've just burned another 15 seconds.
Well, keep burning them, and you'll be up to 2 minutes.
Okay. So your periodic transaction report notes that you were notified of this trade on April 4th, 2016. Did you take additional actions after that date to advance the company that you now own stock in?
I'm offended by the insinuation, Senator.
Well, let me just read what you did. You may be offended, but here's what you did. Congressional records show that after you were personally notified of this trade, which you said you didn't know about in advance, that you added 23 out of your bill's 24 co-sponsors, that also after you were notified of this stock transaction, you sent a letter to CMS calling on them to cease all current and future planned mandatory initiatives under the Center for Medicare and Medicaid Innovation. And just so there was no misunderstanding about who you were trying to help, you specifically mentioned
2 minutes are up,
knee
Senator Warren.
replacement.
Thank you. Senator Warren, who is next? Senator Isakson has 3 minutes.
I want to reclaim my remaining 3 minutes by just making a point. I respect everybody on this committee tremendously. I respect the nominee. But it's very important for us to all understand under the disclosure rules that we have and the way it operates. Any of us could make the mistakes that are being alleged. I'm sure Senator Franken had no idea that he owned part of Philip Morris when he made the statement he made about tobacco companies. But he has a Wisdom Tree Equity Income Fund investment is disclosed in his disclosure, which owns Philip Morris. So it's entirely possible for any of us to have somebody make an investment on our behalf and us not know where that money is invested because of the very way it works. I don't say that to in any way embarrass Mr. Franken, but to make a point that any one of us who have mutual funds or investment managers or people who do that, it's entirely possible for us not to know. And to try and imply that somebody's being obfuscating something or otherwise denying something that's a fact is just not the fair thing to do, and I just wanted to make that point.
This is different than mutual funds.
It's an investment in Philip Morris.
All right.
And my question was about what he did
Senator
after
Warren,
he
your
had
time
notice.
your time has been generously. Senator Kane. No, I'm sorry, Senator Hassan.
I'm happy to lead, but I think Senator Cassidy was next, and he just came back in.
He did, but I was going back and forth. I'll be glad to do you.
Well, thank
that's
you.
generous of you, but
all right. Well, then thank you. And Congressman Price, thank you for being here this morning. Mr. Chairman and Ranking Member Murray, thank you for the opportunity to participate. As you and I discussed, Congressman, we share a concern for patients. My husband and I have 2 kids, and our adult son at times has had up to 10 doctors and a couple of dozen medications. So the Hassan family knows the strengths and the weaknesses of our healthcare system very, very well. And as Governor, I was pleased to work with members of both parties to build on the example that Senator Young talked about in Indiana to have a bipartisan New Hampshire-specific Medicaid expansion plan that's providing coverage now to over 50,000 hardworking granite staters. And so I've seen the advantages of the Affordable Care Act and the flexibility that the Affordable Care Act gives states right up close and worked with the Republican legislature to pass it. So it's that context that I bring to this series of questions. First of all, as we talked about, opioid overdose deaths have been on the rise for several years and have hit New Hampshire particularly hard. We have about the 2nd highest rate of drug overdose deaths in the country. Under the Medicaid expansion program that I just talked about, made possible only by the Affordable Care Act, thousands of New Hampshire citizens are getting the opportunity to get treatment for substance use disorder. And I talked with one of them last week, a woman named Ashley, who had had an addiction for almost a decade. Medicaid expansion gets passed under the Affordable Care Act. She got treatment, and she is now in recovery. And after a year on Medicaid, which, by the way, we've done it in a particular way so that it's actually strengthened our insurance market in New Hampshire because more insurers came in as a result of the way we did Medicaid expansion. Anyway, she's now working, and she's just switched over to private insurance because she's got employer provided insurance. So you have proposed repealing Medicaid expansion in the budget that you proposed. So yes or no, can you guarantee that you will make sure that Americans with substance use disorders who've gotten insurance through Medicaid expansion, just like Ashley did, will not lose their health insurance?
I think that I joined our conversation as well, and the subjects that we delved into. I think that it's absolutely imperative that we as a nation make certain that every single individual have access to the kind of mental health and the kind of substance abuse challenges that they have.
Well, so is that a guarantee that you will find funds to actually provide the treatment?
It's a guarantee that I'm committed to making certain that we address that need, which is so vital and important across this land.
So I'm just concerned that you're not going to be able to back up that guarantee if the Affordable Care Act is repealed. And I'm concerned about the impact that will have on states and people like Ashley who need the coverage. I also just want to talk about whether you agree that people with health insurance should have some very basic essential coverages, like checkups at the doctor's office. Do you think health insurance coverage should provide for that?
I think that as we mentioned, with choices for patients to be able to select the kind of coverage that they want instead of somebody else decides for them, it's so very important that we remember that at the center of all of these discussions is a patient. And the patient knows best what he or she needs. And that's the imperative that I would bring to you, that I'm committed to making certain that patients have the choices available. And if they choose to select that kind of coverage, then they ought to, that ought to be available.
But if insurance companies don't offer it at all, like substance use disorder, so an essential benefit under the Affordable Care Act now, it requires private insurers to cover substance use misuse treatment. They didn't used to do that. They also have stopped covering a lot of things until the law requires them to. So, yes or no, the Empowering Patients First Act would repeal the requirements that insurance companies cover substance use disorders. So do you think that's still a good thing?
I think that what's a good thing, again, is to keep the patient at the center of all of this and make certain that we're providing the kind of options and choices for patients so that they can address their clinical and medical needs.
But see, here's the thing. If insurance companies never offer it, they don't have the option. They can pay good premium dollars, but it's just not offered. And the Affordable Care Act said to the insurance industry, here's some basic things you got to offer so that when a patient needs care, the coverage is there and they can get the care. And your answer and the Empowering Patient Act would take that assurance away. It's not an option if insurance doesn't cover it.
Yeah, the good news for you is that as an administrator, if I'm privileged to serve in that capacity, that I follow the policies that are adopted by the Congress of the United States and signed by the President. And so we look forward to working with you to make certain that those kinds of things are covered and those patients receive the care that they need.
And with respect, there's been lots of opportunity to make certain that those things happen. And until the Affordable Care Act was passed, it never happened. And people didn't get the care they needed. And because of that, a lot of people like the Ashleys of the world weren't getting better, weren't getting treatment. Providers don't exist to treat people if they can't figure out how they're going to get reimbursed. The most important thing that our treatment community said in New Hampshire was Medicaid expansion of the Affordable Care Act made it possible for them to stand up a higher volume of treatment. So I look forward to working with you too, but I'm concerned about your unwillingness to commit to making sure that insurance companies cover these essential benefits. I am almost out of time, and we haven't even touched on the issue of women's health, which is obviously of great concern. So let me just ask a couple of questions. Yes or no, do you think an employer should be able to fire a woman because she uses birth control?
Oh, I don't believe so.
Well, you voted in support of a resolution to disapprove the District of Columbia's non-discrimination law, the Reproductive Health Non-Discrimination Act, which protects women here in D.C. from being fired or penalized because of their reproductive health decisions. So your vote would have had the effect of allowing employers to fire a woman for using birth control or for other decisions she makes about her own body and reproductive health. So how is that vote consistent with the answer you just gave me?
Well, again, I think that it's I think the question was about who's paying for that product.
No, the question is whether an employer who, let's say in a self-insured employer-provided health insurance plan, finds out that a female employee who earned the benefit with her hard work is using the benefit to provide to provide birth control, to buy birth control, which the benefit provides, and then fires her because the employer disapproves of the use of birth control.
I don't think that's the case.
You don't think that? Would
I
you
don't
like us to provide examples for you?
Yeah, I'd be happy to.
So you would be willing to say that employers may not, you would support a law, a rule, that employers may not discriminate against women for their reproductive health decisions?
I don't think that employers ought to, that employers have the opportunity right now to be able to let somebody go based upon their health status or the
So then
medications that
why
they
did you
use.
vote against the D.C. provision that
I don't
would have
think
made
that's what it
clear?
did.
You don't think that that was your vote?
I don't think that's what the bill did.
Well, thank you. We'll follow up on that. And
Thank you.
again, I wish I had more time because I have about 8 more questions. I'll submit them in writing.
Thank you.
Thank you, Senator Hassan. Senator Cassidy.
Thank you, Mr. Chair. Y'all all seem worn out, but I've been gallivanting with high school students, so I'm pretty energized.
Well, good.
Let me say for the record that when John King came for an interview, I wanted to ask a second around, and you wouldn't let me. I confirmed with staff, so I've been wanting to say that for 2 days now, and I'm just going to say it. I got another set of questions. You said shut up. So anyway, next for Price.
Nothing personal.
Nothing personal. For Price, how would HIPAA laws regard now a grandfather taking his grandson on house calls? You know what I'm saying? Somehow I think your grandfather would have been busted, but that's another...
Probably.
Probably. I love what you're saying about the patient-physician relationship. You and I have both worked in hospitals for the uninsured. I, as a gastroenterologist, liver doctor, and we've been talking a lot about Obamacare and wonderful things it's done. But I keep on thinking of my patients at the hospital for the uninsured with a $6,000 deductible.
That's right.
I mean, the patients you saw at Grady, not those on Medicaid, but those who are working, they don't have $400 in their account.
That's right.
And they got a $6K deductible before they can be otherwise cared for. And just for the record, people don't believe me. I put it on my Facebook page. A friend of mine from home, his renewal for his individual policy for he and his wife, 60, 61 years old, no kids, no health stuff, was $39,000 for a year with a $6,000 deductible. I put it on my Facebook page because no one believes this is like what a family pays for a mortgage and then some, and that was their yearly premium. So I applaud you for looking for some alternative that's affordable. It may be working for New Hampshire, California, Massachusetts. God bless you. But for states like mine and yours and Arizona, people cannot afford $39,000 premiums. A little bit more. Did the Empowering Patient Act explicitly repeal the mental health parity laws?
I don't believe so.
Yeah, I don't think so either. But just Senator Hassan, mental health parity would still apply. And that does cover substance abuse. So there is those provisions. That law still remains in effect. Secondly, we've been talking about, does it have to be a covered benefit? If you're a big believer in health savings account, I gather a health savings account can be used to pay for doctor's visits and for essential medical services and even colonoscopies if necessary.
Absolutely.
Yeah, as a gastroenterologist, that comes to mind. So just to also point that out. And when you speak about giving the patient power over her health care, to allow her to choose, when we choose for her, we have a $39,000 premium. But when we allow her to choose, she has something which is affordable and she becomes a more activated, informed consumer. And there's a lot of academic literature to look at that. And I applaud.
Absolutely.
We don't agree with each other entirely, but substantially, and I applaud you for that. Now, Franken always calls me a Luddite. Different issue. Because I am skeptical about, he calls me many things, but a Luddite among them, because I am skeptical about electronic health records and their negative impact upon productivity. And again, he thinks I'm just some guy that calls a mouse a little furry thing when most people have moved even beyond a little. Now, I see that MD Anderson just laid off 5% of their staff. They're blaming it upon financial losses related to decreased productivity, again, directly attributable to the implementation of their EHR. Your department's going to be involved with meaningful use and such like that. And I often find an orthopedic surgeon asking somebody about their smoking history is not really a good use of the orthopedic surgeon's time. Not that it isn't important, But nonetheless, he's not the person who will implement the cessation program. It shall be their internist or, you know what I'm saying. So what thoughts do you have? What can we do about this time and productivity sump that has become the electronic medical record in meaningful use, keeping that which is positive, but hopefully doing something better for the patient and for the physician?
Yeah, thanks, Senator. The electronic medical record and electronic health records are so important because they from an innovative standpoint, allow the patient the opportunity to have their health history with them at all times and be able to allow whatever physician or other provider access to that. We in the federal government, I think, have a role in that, but that role ought to be interoperability to make certain that different systems can talk to each other so that it inures to the benefit of the patient. I've had more than one physician tell me that the final regulations and rules related to meaningful use were the final straw for them.
And they quit. They retired.
They quit. And they've got no more gray hair than you or I have. And when that happens, we lose incredible intellectual capital in our society that can care for people.
Now, what can we do about that? What practical things can we do?
I think the thing that's absolutely imperative is to find out what things ought to be determined and checked, and the metrics that are used, that they actually correlate with the quality of care that's being provided, as opposed to so many things that are required right now of the physician or the provider that make it so that they're wasting their time documenting these things so that that fits into some matrix somewhere, but it doesn't result in higher quality of care or outcomes for that patient. So if we truly worked with those providing the care to say, what is it that we could ask you to measure that would really correlate with the outcome and the quality of care being provided, I suspect there's some very specific things that we could use.
You know, it's interesting because if you're emphasizing the patient-physician relationship. Yeah. My wife's a retired breast cancer surgeon, and she used to say that really she canceled the husband as much as the wife, because the husband would be the one who was crying.
Yeah.
But she would be the one telling them, looking them in the eye, there's hope. This is not a death sentence. There is hope. And I only imagine if she were now in practice typing up, there is hope.
Yeah.
It's a little bit of a different feel for the patient and her spouse.
Yeah, we've turned many physicians and other providers into data entry clerks, and it detracts, as you said, from their productivity, but it detracts greatly from their ability to provide quality care.
Let me ask as well, one of our big challenges, how do we come up with expensive medicines that are only used by very few? How do we socialize that cost? Think of antibiotics. We just have some gorilla, you know, some germ out there, bacteria that's apparently resistant to everything. But we can come up with gene therapy for a very few, very expensive to develop. How do we pay for that? I just want your thoughts. I don't know if you have an answer, but since I care deeply about those, and so do you, with these rare diseases but devastating, how do we care for them and socialize that cost?
Talked earlier with Senator Hatchett during his time about rare diseases and about the Orphan Drug Act and the like that revolutionized the ability or the incentives for bringing to market drugs that address rare diseases, and it's so incredibly important. And incentivization from an FDA standpoint is important. Incentivization to make certain that if individuals, companies are able to come up with things that cure diseases, that they are appropriately compensated.
Now, in the era of personalized medicine, where it might be an N of 1 or an N of 1,000, still very small, but the cure could be 1,000,000. Anything specific about that?
We're entering a brave new world that is so exciting from a scientific standpoint to be able to provide this kind of personalized health care services to folks that will be able to cure things that we've never dreamed about curing. And the challenges of how we afford to make that available to our society are real. And I think we need to get the best minds together to figure out how to make that happen, and I look forward to working with you to do so.
I'll close by saying this, and I have a perspective that my colleagues cannot, because I know orthopedic surgeons are the ones that are called at 3 in the morning when there's a car wreck and someone's so busted up there's no one else to fix them. But if they don't fix them, they die. And so they kiss their wife goodbye. They climb out of bed, they drive to the hospital, they're up all night, and then they see their clinic scheduled the next day. They make rounds in the evening, they get home at midnight and kiss their wife goodnight before they go to bed. Price, you're the exact kind of person to have this job. Thank you, and I yield back.
Thank you, Senator.
Thank you, Senator Cassidy. Senator Kane.
Thank you to the committee leadership, and thank you, Congressman Price, for the visit the other day in the office.
an observation, then a few questions. And forgive me, I was at another hearing, so I might be a little repetitive, but I'll try to move quickly. My worry as a Virginian is your position about a whole range of programs that are basically about access and coverage, sort of the safety net that provides coverage to millions of people. You've proposed turning Medicaid into a block grant program. That's exciting a lot of controversy in Virginia right now in our legislature, both Democrats and Republicans, and you have repeatedly voted against the CHIP program for kids, at one point calling it socialized medicine. That's a combined Medicaid and CHIP, about 800,000 Virginians. You've proposed a restructuring of Medicare that CBO found would increase out-of-pocket costs for seniors. That's about 1.3 million Virginians. You support repeal of the Affordable Care Act. There's about 500,000 Virginians on the exchanges and hundreds of thousands of others that are otherwise benefited. You want to defund Planned Parenthood. Tens of thousands of Virginians use Planned Parenthood as their primary health care provider. These are the basic programs that provide health care coverage for millions of Virginians. There's some overlap there, but it would be millions of our 8 million and tens of millions of Americans, and many of them have very limited means. And so there's a sort of consistency to your position in some ways across all these programs that I view as critical to the health safety net. I know that Senators Franken and Murray used the Hippocratic maxim, first do no harm, in comments before I came. And I think, and I would hope you would agree, that as we approach the discussion of the healthcare system, access, coverage, cost, quality, the President and Congress should strive to do no harm. Would you agree with me?
Absolutely.
And we shouldn't harm people by reducing the number of people who have health coverage or reducing the quality of the insurance coverage they do have. That's what we should strive for, right?
I think it's important to appreciate that there are challenges in these programs currently. Mm-hmm. 1 out of every 3 physicians who ought to be able to see Medicaid patients across this country doesn't see Medicaid patients. Mm-hmm. If we're honest and sincere about addressing these problems, we ought to step back and say, why is that? What are we doing wrong? So 1 out of every 8 physicians who is eligible to see seniors no longer sees Medicare patients. If you're a new Medicare patient trying to find a physician a new physician that sees new Medicare patients, it's almost impossible anywhere in this country.
I am all with you on fixing challenges and going forward, more coverage, more affordable,
and that's what we're trying to do. That's what my proposals have tried to do.
That is important. We shouldn't harm people by doing things that would increase their costs, correct?
I think we need to drive down the cost for everybody.
Right. We shouldn't harm people by creating an anxiety about the most important thing in their lives, their health care and the health care of their families. We shouldn't be doing that in Congress, should we?
One of my goals in this entire debate, and I appreciate you bringing this up, is to lower the temperature about what we're talking about, because this is real stuff for folks. These are their lives and their health.
Can we lower the temperature and rush at the same time?
I think we can move apace but lower the temperature and provide stability to folks out there. People need to know that no rug is going to be pulled out from under them.
I'll join you in stability and I'll join you in lower temperature. I don't think lowering the temperature is consistent with rushing. In fact, my experience in going around Virginia is huge amounts of fear. And we shouldn't harm the American economy. Healthcare is the biggest sector of the American economy, 1/6 of it. By injecting uncertainty into it, we should, again, try to fix the problems that you've identified or those that I might identify and do them in a way that provides some stability and certainty. Shouldn't that be our goal?
Yeah, certainty is incredibly important. I'm reminded of the fact that the Congressional Budget Office has told us that the ACA has actually decreased the workforce by the equivalent of 2 million FTEs. So there are challenges that we have throughout, and I'd hope that what we're able to do is to work together to solve those challenges.
Do you agree with the President-elect that the replacement for the Affordable Care Act must ensure that there's insurance for everybody?
I have stated here and always that it's incredibly important that we have a system that allows for every single American to have access to the kind of coverage that they need and desire.
And he stated in the same interview a couple of days ago that we should negotiate with pharmaceutical companies under Medicare Part D to try to bring down prescription drug costs. Do you support that position of the President-elect?
I think that the cost of drugs is in many instances a real challenge for folks, and we need to do all that we can to make certain that we bring those costs down.
Here's kind of an offbeat question that's just a coincidence based on today. I was at a hearing with Nikki Haley, Governor Haley, who was nominated to be UN ambassador right before I came in. she played a really significant role in moving her state away from use of the Confederate battle flag in any official capacity. When you were a member of the Georgia legislature, you fought pretty hard to keep the Confederate battle flag as part of the Georgia state flag, and you sponsored resolutions to make April Confederate History Heritage Month in Georgia and, quote, urging schools to commemorate the time of Southern independence. And I'd like to introduce that resolution for the record, Mr. Chair. I read the resolution with interest because of the phrase commemorating the time of Southern independence, and I pulled it up. And I note that the resolution that commemorated the time of Southern independence mentions nothing about slavery. Why did you support that resolution, and do you still support it today?
Well, I haven't thought about that in a long time, Senator, but I'm happy to look at that and go back and try to refresh my memory about that
time. Set the resolution aside. What's laudatory about the time of Southern independence?
Well, I think every heritage has things that are good about it. Every heritage has things that are harmful about it. So I'm happy to answer a specific question. I think slavery was an abomination.
Do you think a history resolution about Confederate History Month that completely omits any reference to slavery is, kind of meets the basic standards of, fair balance?
Well, I don't know that it presumed to be comprehensive. What I do know is that the work that I did as the first Republican Senate Majority Leader in the history of the state of Georgia was to make certain that we came forward with a flag that did not have the Confederate battle flag on it, that addressed all of the concerns of the state and was adopted and supported by the state. And we did so in a bipartisan way. And I was privileged to work with now Atlanta Mayor Kasim Reed when he was in the United States, when he was in the Georgia Senate at that time, to make certain that we were able to do so.
You're aware that there's an Office of Minority Health at HHS that was created in the Affordable Care Act, reauthorized in the Affordable Care Act, and that if the ACA is repealed, unless it's separately reauthorized, that office would also expire?
Again, that's a legislative question. If I'm privileged to serve and be confirmed and be Secretary of Health and Human Services, I look forward to making certain that we use the resources available to us and the agencies available to us within the department to make certain that every single American has the highest quality health care available.
And why did you use the phrase socialized medicine to explain your vote against the CHIP program?
I don't know that I recall that conversation or that quote, but I'm happy to go back and look at it.
Okay. Thank you. Thank you, Mr. Chair.
Thank you, Senator Kane. Senator Scott.
Thank you, Mr. Chairman. Dr. Price.
Senator.
Good to see you here today.
Likewise.
Hoping for much success for you. Did I hear that you were at Emory University?
I was.
Medical school?
No, I did my residency at Emory University.
Okay. My nephew just is in his first year of medical school at Emory. I hope that he gets a quality education at that school.
He will, and he's got an exciting road ahead.
Excellent, excellent. Well, I did have the privilege of serving with you in the House, and enjoyed our relationship, our friendship, and look forward to seeing your success as the Secretary of HHS. I have a couple questions that are state-specific to South Carolina. We have over 20 health centers in South Carolina with about 165 service sites, serving over 350,000 patients in almost every county in the state. Every county in South Carolina is either partially or completely designated as medically underserved by HRSA. As rural hospitals continue to close, these centers have addressed a need for many communities in my state. They work together with partners in the community to address impacts on health, like food deserts and lack of transportation to preventative health services, which can save cost in the long run. A diabetic who does not take their medication because they cannot afford it or has no way of picking up what will inevitably be a long run to the emergency room. What role do you think community health centers can play, particularly in rural and medically underserved areas?
Thank you, Senator. Community health centers are a vital part of our health care delivery system right now. They fill a void in so many areas, as you mentioned, across your state and across mine, and literally across the country. I think there are over 13,000 that are the entry point and oftentimes the area of health care for so many individuals, and we need to do all that we can to strengthen them, to make certain that the providers, the docs and other providers that are within community health centers are of the highest quality, that they're providing the highest quality care, and that they're able to access resources, intellectual resources and clinical resources that allow them to provide that care.
Less than a decade ago in South Carolina, emergency rooms were full of people waiting for psychiatric exams so they could either be admitted or discharged. After implementation of a statewide telepsychiatry network, wait times have been cut from 4 days down to about 10 hours. The cost have been cut by almost 2/3. What do you see as the future of telemedicine, particularly to address access issues? What barriers can we anticipate as well?
Telemedicine is one of those exciting innovations that will, I believe, allow for individuals, especially in rural and underserved areas, access to that intellectual capital and resources from a clinical standpoint to make decisions on patients that are before them without being able to save resources and save patients in so many ways. We in the state of Georgia have a stroke program that's kind of a spoke and wheel program where at the Medical College of Georgia there's a neurologist that works with telemedicine and has a network of clinics and hospitals around the state where if somebody comes in with symptoms of a stroke, that physician is able to literally see that patient in real time and determine, one, whether or not they need medication, whether or not they're having a stroke, whether they can be treated in the community, or whether they have to be transferred to the academic center. In the past, it was a call on the ground, no ability to be able to talk with somebody who might have greater resources or knowledge, and all of those patients tried to get to the academic center. Huge wastes of money and not having patients at the center of that decision. So telemedicine is absolutely vital, and I think we need to accentuate the ability to use telemedicine. As you well know right now, oftentimes telemedicine, telehealth is not paid for. It's not compensated. So people eat those, the clinicians eat those costs. They assume those costs that help the patient, yes, but make it so it's much more difficult for them to be able to provide the quality care necessary.
Thank you. Another interesting topic that you should be, I think, fairly familiar with from a minority perspective. South Carolina, like Georgia, has a high percentage of African Americans. As you probably know, breast cancer deaths are approximately 1.5 times higher in African American women. Prostate cancer deaths are approximately 2.5 times higher in African American men. And new diagnoses are approximately twice as high. I would love to hear your perspective on addressing some of the health disparities in communities of color specifically.
Yeah, this is really an important area, Senator, and I appreciate you bringing it up, because I think so often what we do in this and other areas is to say, okay, we're going to set up this facility here or this agency here, and we've taken care of the problem. What I don't think we do is look at the what's happening on the ground, the metrics as well as we could or should. We ought to be defining specifically whether or not we're actually improving the lives and health for individuals in challenged communities. And if we're not, then we need to step back honestly and sincerely and say, what can we do to make certain that it works? I learned a couple months ago, I had the privilege of being at a clinic in Atlanta, and I learned that there's a zip code in Atlanta within this metropolitan area of Atlanta that has incredible disparities in terms of their health outcomes and their health status. Higher mortality, higher rates of diabetes, higher rates of stroke, higher rates of myocardial infarctions, and they're surrounded by incredible health care facilities. And when we see those kinds of things, we need to drill down into those areas and say, what's going on? Why is that happening? And address the real challenge on the ground, as opposed to saying, okay, we've taken care of it because now we have an agency that's addressed to take care of that. I think we need to do better metrics and better accountability for what's going on.
I'm sure that you guys have talked at some length about rare diseases.
We have.
Sickle cell being one of the more important ones in the African American population. I would love to perhaps submit some questions for the record to get your insight and your perspective on how we tackle so many of those diseases moving forward.
Look forward to that, Senator. Thank you.
Yep, thank you.
Thank you, Senator Scott. Senator Murray.
Thank you, Mr. Chairman. Congressman Price, I did want to clarify your response to one of my previous questions. You admitted to me in our meeting that you, in your own words, talked with Congressman Collins about innate immuno. This inspired you to, in your own words, study the company and then purchase its stock. And you did so without a broker. Yes or no?
No,
Without a broker.
I did not.
You told me that you did this one on your own without the broker. Yes?
No, I did it through a broker. I directed the broker to purchase the stock, but I did it through a broker.
You directed the broker to purchase particularly that stock.
That's correct.
Yeah. Well, Mr. Chairman, those answers really commit me to underscore the need for a full independent investigation, and I would like to ask consent to enter into the record an article from Kaiser Health News that notes that Congressman Price was offered a lower stock price for sophisticated investors. I think that's an important part of the record.
Will be included.
Representative Price, if you are confirmed as Secretary of Health and Human Services, you will be in charge of our nation's family planning programs and policies. You have said that you don't think cost is an issue for women in buying birth control and stated, and I quote, "Bring me one woman who has been left behind. Bring me one. There is not one." You did say that, correct?
I think what I said and what I meant was that when I had patients in my office who were unable to afford medication, we did everything we could to make certain that they got that medication. And what I meant to capture in that conversation was that if there are individuals who are unable to afford that medication or any medication, that there are avenues within the healthcare system that physicians and others take to make certain that individuals receive the medication that they need.
Well, let me tell you about my constituent Shannon. Shannon has endometriosis. It's a common health condition impacting women. And she said, and I quote, "No copay birth control is an essential tool helping women like me with endometriosis who otherwise would have to live with chronic pain." So no copay birth control was extremely important to her. She's just one. You know, women are really deeply concerned about the impact this election could have on their access to health care that they need. I have heard from many of them. And according to Planned Parenthood, demand for IUDs, which is a form of long-lasting contraception, is up 900% since the election. So I want to ask you, will you commit to ensuring all 18 FDA-approved methods of contraception continue to be covered so that women do not have to go back to paying extra costs for birth control?
What I will commit to and assure is that women and all Americans need to know that we believe strongly that every single American ought to have access to the kind of coverage and care that they desire and want. And that's our commitment, and that runs across the board.
Well, let me be clear. Birth control is an essential part of women's health care, and if you are confirmed, I will be holding you accountable for that. I also wanted to ask you, I'm deeply concerned about the impact of your policies that would have on women, obviously, and in particular women who often face barriers to accessing the health care they need. According to HHS data, since the ACA became law, the percentage of black women who report not having a regular doctor dropped by nearly 30%, while that measure for Latinas fell by almost 25%. Your health care repeal bill and your budget proposal to cut $1 trillion from Medicaid would disproportionately hurt women of color, further compounding disparities in access to health care and undoing progress that was made in the Affordable Health Care Act. Are you committed to ensuring that women of color maintain access to quality, affordable Medicare?
Senator, I appreciate it. I don't agree with the premise. The program that I support and that I believe the President supports is to make certain that every individual has access to the kind of coverage that they want. Nobody wants individuals to not have the opportunity to see the doctors that they want, to get the kind of care that they want at a price that's affordable and that's of the highest quality. That's what we believe in, and I hope that we'll be able to work together to achieve that goal.
Well, the Office of Minority Health was reauthorized as part of the ACA. So will you commit to maintaining and supporting this office and its work?
I will commit to be certain that minorities in this country are treated in a way that makes absolutely certain that they have access to the highest quality
So
care.
you will not commit to the Office of Minority Health being maintained?
I think it's important that we think about the patient at the center of all of this. Our commitment, my commitment to you, is to make certain that minority patients and all patients in this country have access to the highest quality care.
But in particular, so you won't commit to the Office of Minority Health?
Look, there are different ways to handle things. I can't commit to you to do something in a department that, one, I'm not in. I haven't gotten there yet.
But you will be. You will be.
Let me put forward a possible position that I might find myself in. The individuals within the department come to me and they say, we've got a great idea for being able to find greater efficiencies within the department itself, and it results in merging this agency and that agency, and we'll call it something else. And we will address the issues of minority health in a big way and make certain that it is responsive to patients.
Let me just ask you one final question. As you are aware that are you aware that Black, Latina, American Indian, Alaska Natives are almost twice as likely as white people to be covered under Medicaid? Do you think it's responsible to propose cutting trillions in dollars of funding without a credible alternative to replace it for those ones?
Again, I disagree with the premise. The solution that we have would ensure that every single American, regardless of their health status and regardless of their economic status, have the ability, financial feasibility, to purchase the kind of coverage that they want.
Well, I have a few seconds left, Mr. Chairman. As you can see, we have members here who also have additional questions. I am deeply troubled by a number of responses. We have a lot of families who are very, very, very concerned since this election what will happen to them personally. We've outlined some of those, and I hope that Congressman Price, as we will have a significant number of questions from our colleagues, that you will fully submit them for the record.
Thank you.
Thank you, Senator Murray. Dr. Price, I want to thank you for being here. I only have a few comments. I don't have additional questions. I was reflecting back on Sylvia Burwell's appearance before this committee and how impressed I was with her appearance. I think you have done as well. I've also been impressed with her performance in the job because while I disagree with a number of the policies she's taken, she's gone out of her way to adopt the same tone that I've heard from you today, which is to try to accept and work with people with different points of view and see if we could come to a consensus. So I thank you for that, and I'm impressed with your beginning and and I appreciate your being here today. Based upon the figures I have, you've just endured the most extensive questioning of any Secretary of Health and Human Services since 1993. Because of the round of questionings, Secretary Burwell was in the hearing for 2 hours and 10 minutes, Sebelius for 2 hours and 28 minutes, Daschle for 2 hours and 10 minutes, Levitt less than 2 hours. I don't have it for two others. You've been here nearly 4. And next Tuesday, you'll go before the Finance Committee, which will vote on whether you go forward to the President. I'm very hopeful that your tone will help us come to a conclusion and a consensus in this very important area of providing concrete, practical alternatives to give Americans access to health care they can afford. I was reflecting last night on the hearing and today. They've been pretty testy. We often have strong opinions here because we have differences of opinions, but I think that's a reflection of, one, the election over the past year, which became very uncivil, more so than I liked, and Republicans can take our share of the blame for that. But also this issue, which for 6 years we've been going at it like the Hatfields and the McCoys in West Virginia until almost we've forgotten who killed who in the first place, and we don't know, we're not absolutely clear what we're fighting about. So it would take a bedside manner such as you have to lower the temperature, as Senator Keynes suggested. He and 12 Democrats, he was among 12 Democrats who wrote a letter suggesting they were willing to work with Republicans as we go forward. I think it will take a little while to lower that temperature just because we've spent 6 years as Hatfields and McCoys, but I'm committed to trying. That's the way we usually work in the committee on very contentious issues. And I'd like to get away from the testiness of last night and today and back toward the way we've learned to work. A couple of other things. I hope those watching are reassured by what they heard from you. What I heard from you, I believe I'm correct about this, is that while we intend to repair the damage of Obamacare, and that would eventually mean repealing parts of it, major parts of it, that won't become effective until there are practical, concrete alternatives in place to give Americans access to health care. In other words, you said we don't want to pull the rug out from anybody, and I'm sure that's a shared view. You've talked some about the importance of March the 1st. One thing we have to work together on is what do we do about the individual market, and the fact that in a third of the counties there's already just one insurer for people with Obamacare subsidies, and we don't want to get into a situation later this year or in 2018 where there's, as I said, it's like having a bus ticket in a town with no buses. So we may have to do some things on both sides of the aisle that we wouldn't normally do during this transition period to make sure that insurers are willing to sell into the market so these 11 million people continue to buy insurance, hopefully for more than one person. I think it's also become clear that the timing that we've talked about is yet to be resolved, really, and sequencing is as important almost as the policy. I mean, how do we get from where we are to where we eventually hope to go? And the way I think about it is that we go to work immediately on what I call a collapsing bridge, repair it, that's the individual market, make sure that people aren't hurt by it, and then work together to build new bridges, and then close the old bridge only when we have new bridges up. I think we can make most of the decisions about the quote replacement or replacements or the new systems, new bridges, in a relatively short period of time. We've been working on this for years. We have our opinions. We ought to be able to sit in a room and come to a conclusion. In my opinion, then, it will take several years to actually implement those decisions, because in many cases we'll be transferring responsibility to states, and consumers will want to do that after talking with governors and insurance commissioners, do it on a schedule that states can accept. Their legislatures sometimes only meet every 2 years. So making decisions promptly, making them together if we possibly can, and then implementing it step by step and carefully so that people are able to have access to lower cost insurance is what I hope I heard today. And one other thing, Senator Cassidy, Senator Whitehouse, several members of this committee, maybe all of us, worked very hard, I know Senator Murray did as well, on trying to deal with the electronic health care records and meaningful use. At Vanderbilt, which was an early adopter of the electronic health care records, they said stage 1 was very helpful, stage 2 they could deal with, and stage 3 was terrifying. And I had hoped that we could delay stage 3, and I've thought that maybe it could be as simple as saying to the physicians and providers of the world, look, if you're a doc and you're spending 50% of your time filling out forms, then either you're doing something wrong or we're doing something wrong, and let's work together for the next couple of years to see if we can get that down to a manageable level and create an environment where physicians and providers can spend their time talking instead of typing. So you've got a bipartisan consensus here to work on that. At least we had last year when we passed the Cures bill, which had a number of provisions in it. We had 6 hearings on the subject, and I invite you to work with us if you're confirmed to complete that. If senators wish to ask additional questions of our nominee, questions for the record are due by the close of business on Friday, January 20th. For all other matters, the hearing record will remain open for 10 days. Members may submit additional information for the record within that time. The next meeting of our committee will be an executive session on January 24th at 10 a.m., which has already been noticed. Thank you for being here today. The committee will stand adjourned.
Thank you, Mr. Chairman.
Saying they weren't
While we're creating new concrete alternatives for insurance and eventually replacing and repealing some of the existing ones. So that only affects 4 to 6% of the people with insurance in the country, but those are 11 million people. And the insurance companies are saying that by March the 1st, they need to have some indication of what we're going to do to stabilize the market. So I think that's a rescue plan for the Obamacare exchanges, which are collapsing, is clearly the first order of business. Then I think we wait to see what the President-elect suggests, work with the House of Representatives and begin to see what new alternatives we can come up with. The governors will all be here March 19th through the 22nd. It would be a logical time for Dr. Price, if he's confirmed, to talk with them about more Medicaid flexibility. The employer market is a separate matter. A lot of that doesn't need to be changed very much. The small group market probably does. And there's steps that we can probably begin to take right away on that. So once you put Medicare aside and focus on those three areas, I find a lot of steps that we can take and begin a process that will go on for eventually several years.
And these would be separate pieces of legislation, not just...
Step one, yes, these would be separate pieces of legislation. Some might be in the first reconciliation bill. There's another reconciliation bill that's expected before summer. It would be good if we could have a rescue plan for the individual market that could get 60 votes in the Senate and could be passed the way things regularly should be. That'd be a good step back from the Hatfields versus McCoys that we've been in for 6 years.
Senator, can I ask you specifically has told you guys that Obamacare is collapsing. Have you talked to any health analysts in CMS? Anybody who kind of has the data and is looking at it and saying, look, this is something...
State Insurance Commissioner of Tennessee says the state insurance market in Tennessee is, quote, in virtual collapse. And in our state, premiums are up 40 to 60% this year. Blue Cross pulled out of our 3 biggest metropolitan markets. In 2/3 of our counties, those who have Obamacare subsidies only have one insurance company from which to buy. And across the country, that's true in many other states. So there's almost no one who will tell you that the Obamacare exchanges are not virtually collapsing in many parts of the country. And unless we act by around March the 1st, people will not be able to buy insurance with their subsidies, and we do not want that to happen.
Senator Alexander, I wanted to ask you about the DeVos hearing from yesterday.
I think I said we had 3.5 hours of that last night.
I know. Can I just get 1 minute at a time?